see that there is a good cellularity. In fact, we can say there's a mixed cellularity, like a diploid. Yes. And again, focusing on the left side, let me just magnify it a bit further. Yeah. So the next thing which we have to note is the boundary of this mastoid cavity. So this is the sigmoid sinus plate area. So we have to see whether there is any erosion or dehiscent bone in this part. So scrolling from up to down. Yes. So I think it's well evident. Let me just magnify. There seems to be some erosion here.
Yes.
Let me just focus it a little.
Yes, this is the area.
This is the area. Yeah. So again, we have to look at the lateral cortical bone. So again, scrolling from above downwards, we can see that there is bony continuity. There is no dehiscence in the lateral part. Then the next thing to note is the tegment plate. Now, tegment plate is best studied actually in the coronal views. So let me just bring the coronal view into the picture. Yeah. So if we go from anterior to posterior, when the cochlea becomes visible here, focusing on the left side. So when the cochlea becomes visible, the tegment which corresponds to the level of the cochlea, that's the tegment tympani. So we can see that there is a iso, or we can say hypodense lesion here. And there is a bit of scalloping here, but the bone is intact in the tegment tympani. Then moving backwards, now the semicircular canals are coming into view. Yeah, so at the level of the semicircular canal, the corresponding tegment plate is the tegment antri. So here also we can see some thinning, some scalloping, but the bone is intact. The next important thing in coronal section, since we are viewing the coronal sections, is the we can trace the fascial. So coming from down to above, let's just focus on this point. We can see the fascial going upward. So can you appreciate?
Yeah.
Yeah, this is the lateral semicircular canal. The fascial is just below it here. And as I was studying, I just found maybe there might be, I don't know, intraoperatively, it will give us a better picture. But I find that there might be.
Dehiscent.
Yes, sir. Yes, sir.
Dehiscent fascial.
Let me just magnify it further. This one, sir.
Yes, I agree. I agree, dehiscent fascial.
Yes, sir. So just below the lateral semicircular canal. So we have to be careful during the surgery in this part. Then we have to look also at the bony boundaries of all the semicircular canals. So if this is a superior, so we have to see the bone around it. Scrolling up and down, if we see that there is bony continuity all around.
Yes.
Again, in the lateral semicircular canal, we see bony continuity. Also in the posterior semicircular canal, we see there is bony continuity. So there doesn't seem to be any dehiscence in the semicircular canal. Now let's go back to the axial scan again. So we have noted the fascial in the coronal section. Let's also note it in the axial section. So this is the internal auditory meatus.
Yes.
Anything lying anterior to it is the cochlea. Anything lying posterior to it is the vestibule and the semicircular canal. So let's just trace the facial nerve. So this is the bird beak appearance coming into view. The first the labyrinthine portion of the facial nerve. Then this is the first genu. This is the GSPN.
This is the tympanic segment.
Yes, tympanic segment. And we can see that there is bone here in the tympanic segment. Then coming down, Here there might be some dehiscence in this area. As we were looking there, there might be some dehiscence in this part, sir. Here. So tracing it down further, the rest of the part of the facial nerve seems fine. Only in one particular point there might be dehiscence, just near to the lateral semicircular canal. Then we have to know the extent of the pathology. Now we see some iso or hypodense lesion or opacity in the whole of the mastoid antrum. There is widening of the adductus area. Then this lesion is occupying the whole epitympanum and almost the whole of the mesotympanum. And we have to note the status of the ossicles. Now, if we note the ossicles, this is the tympanic membrane. It seems to be thickened and medialized. And if we trace it all through, up and down, again and again, we can just see that only some remnant part of the ossicle is there. There is no continuity of this ossicle up to the oval window area. This might be malleus because it is near to the tympanic membrane. And this seems to be the stapes, but this is not stapes actually. This is some maybe fibrous band because this is the carotid artery. This is not the area of the stapes.
Yes, carotid, yeah.
Yes. So again, scrolling up and down, this is the extent of the lesion. The hypotympanum seems to be a little free in relation to the other part, but the rest of the part is filled with the lesion. Now, next important thing to note is the jugular bulb.
Yes.
We can compare it on both the sides. If we see the
higher.
right,
It is higher on the left side.
Yes, sir. Yes, sir. So if we compare it with the right side, we can see that the bony thickness is more on the right side in comparison to the left side. So we have to be careful when we are doing work in the middle ear.
Yes.
So another thing we can note is the promontory area. So we see that there might be a little erosion here. It's not very clear. And the rest of the inner ear looks normal. Yes, this was, I think, how much I could decipher from the CT scan. I think respected Pukon sir or Mukherjee sir or Khan sir can add some more points to it.
You have nicely explained everything.
You have explained everything.
Have you done any, Mukherjee, wait. Have you done any MRI? Nothing, no?
No, sir.
Why
no,
diffusion
sir.
weighted MRI is needed for cholesteatoma?
Yes, sir. So what happens is the lesion which we see here, this hypo-intense or iso-intense lesion, we cannot comment that this is cholesteatoma.
Yes.
This might be collection,
Correct.
this might be hypertrophic mucosa, this might be some secretion. It's only through the diffusion weighted MRI that we can say that this is cholesteatoma.
Yes.
There are many papers on this in various journals also about comparison of the preoperative CT scan and operative finding.
Yes,
And
sir.
the fallacies. I think diffusion weighted MRI gives some solution. Sanchita,
Yes, sir.
DW weighted MRI gives some solution, no?
Yes, sir. Yes, sir.
You have given fine, no, actually. Mukherjee, do you anything you want to comment on?
No. It's
Very nice.
She has explained so nicely everything.
Everything.
Whatever she tells, I agree with her because the jugular bulb appears to be prominent on this
That's
side.
okay, but don't repeat. But it's okay. They all just explained. But ossicles also only part little ossicles may be there.
Yes,
Malleus
sir.
may be there. Malleus. That too. A part of the head.
I just remembered one more point. We can look for the adenoid also from the CT scan.
Yeah.
So
Axial
here
view.
this, yes, sir, axial view. So here we can see the prominence of the adenoid.
Yeah, adenoid is there.
Yes, sir. So intraoperatively, I think Biswa sir can show us the adenoid.
Yes.
Okay, sir, then I will close and hand over to Biswa sir.
Yes.
Thank you, sir.
Thank you very much, Sanchita. Very nice presentation with
Thank
all
you, sir.
DICOM software. I think those who have seen, I think, see how the DICOM software can delineate in every slice, different slice of the anatomy of the temporal bone, particularly the extension of cholesteatoma and any risk in the pathways of the cholesteatoma. And I think Gautam will explain more in this presentation. Something. Why has got
Fukan
some?
sir? Fukan sir?
Gautam has got a presentation, no?
Counselor, yes, sir. Counselor is already here. So I think Counselor can continue with the presentation as Biswa sir gets ready with the case.
Yeah.
Counselor, are you there?
Give me a minute. Give me a minute. Please give me a minute.
Sure, sir. Sure, sir.
You want me share? You want me to share the screen?
Yes, sir. You can go forth with the sharing. So you've already been made co-host. I've stopped the screen sharing.
Okay. All the dangerous people are there. I'm afraid to give my presentation after Sanchita's so lucid presentation.
Yes, Sanchita is giving very nice presentation.
I have developed an inferiority complex today. Is my
You will
presentation
not
visible?
develop it. Why? Never develop an inferiority complex.
Is my
Keep your head
presentation
high.
visible?
Yes, sir. It's
Yes,
visible.
yes, nice.
Fine. So, Biswajit actually heard that I have to give a presentation for this thing, for a particular Alembic, I think, has organized this, because they were contacting me through a third party. So what they did is they asked me to give this talk on cholesteatoma staging and classification. And Biswajit said, why don't you give this talk here? But that talk will be actually for 1 hour. So my talk is actually not fully ready, but still then I thought I will try to do what Biswajit has commanded. And so now it is 10:35. I'll try to finish by 5. I'll go a little fast because there are many things which are not directly related to the colic classification. So I'll take you through a little bit about the cholesteatoma classification and staging. But before we do that, I'll just take you around through some interesting points regarding cholesteatoma, the history as well. Well, we know these are the different definitions of cholesteatoma which has been given in literature. Skin in the wrong place by Robinson actually is a very simple and apt definition of cholesteatoma. If you look at the history of the name, in 1683, Duvernay reported a case of cholesteatoma-like symptoms. That was the first report. Then Creweiler described a pathological condition which he referred to as the pearly tumor pearly. And Muller, a German anatomopathologist, actually coined the term cholesteatoma to describe a tumor that appeared greasy in nature. Now, Craigie actually coined the term margaritoma. In 1927, Skupnet called it keratoma, but the term cholesteatoma struck, even though it was a misnomer. Sorry. So we have different types of cholesteatoma. As you know, we have congenital cholesteatoma, we have got acquired, primary or secondary, we have unclassifiable group, and some people try to include a fourth group called the post-surgery or the residual. There are various theories of cholesteatoma formation. We won't go into details. I'm just going through as a sort of recap before Biswa starts his cholesteatoma surgery. We have the epithelial cell rest theory, the invagination theory, we have the retraction pocket theory, the epithelial migration theory, and the squamous metaplasia theory, and the basal cell hypertrophy theory. We know that the clinical symptoms are otorrhea, which is the often scanty and foul smelling. In the earlier times, we used to actually take a swab stick and actually used to take the smell. Nowadays, I think the young people don't do that anymore. Hearing loss is usually conductive, but it could be sensorineural or mixed. There could be presentation with tinnitus and pain, with vertigo, facial weakness, and diplopia as well. And when we examine, sometimes actually when you have a history of scanty discharge off and on, and we see a small scab or a clot on the pars flaccida in the attic, we have to remove it to see if something is there. And then granulation can also be present in some foul smelling discharge, as we have mentioned already. There could be hearing loss, which is conductive on the tuning fork test, facial palsy. There could be fistula sign, positive lateral rectus palsy, or postural lobster, or many other symptoms related to the various complications that can occur with a cholesteatoma. Well, this is again Biswa's video only, which I am playing. He does not know that it is with me, which shows a retraction pocket and the handle of malleus. So your examination has to be very thorough. Now, what are the imaging things we do? Sanchita has explained the CT scan so nicely, but CT scan has got high sensitivity but low specificity. So what do we mean by that? CT scan can tell us that there is a soft tissue in the mastoid. It can tell us the extension. It can give us the roadmap, but it cannot tell you exactly whether it is granulation or cholesteatoma or something else. CBCT, as we all know, has got the advantage of low ionizing radiation, and DW weighted DWI MRIs are useful, and non-EPI DWI MRI has got less false positive, so it is said to be the most useful, especially for assessing the year after intact canal wall surgery. So I won't go to the X-ray radiology things. Why do you have bone resorption in cholesteatoma formation? There are a lot of theories. Inflammation is said to be one of the causes. Local pressure of the expanding mass could also cause bone resorption. Specific cytokeratins could be there. Granulation tissue produced by the lysosomal enzymes, collagenase and prostaglandins. Excessive host reactions, paracrine and autocrine secretions. Angiogenic growth factors like cyclooxygenase 2, interleukin 8, platelet-derived growth factors, epidermal growth factors, and vascular endothelial growth factors released by the inflammatory cells in the matrix and perimatrix, and upregulated cytokines such as interleukin 1, 6, and 17 and interferon beta also promote inflammatory bone resorption. These are recent actually. Matrix metalloprotease 9, MMP9, can degrade type 4 collagen. Receptor activator overexpression of nuclear factor KB ligand called RANKL and low expression of osteoprotegerine OPG in cholesteatoma. Sorry, not perimatrix, it will be perimatrix, it should have been. It's autocorrection actually. And also the colonization of bacteria in the, along with the cholesteatoma in the middle ear and the mastoids, with the resultant formation of biofilms, can aid in the persistence of inflammation. Then this also helps in bone resorption and destruction. Well, we should ideally send every sample for HPE. For requirement of a diagnosis of cholesteatoma, we need a combination of squamous epithelium, granulation tissue, and keratinous debris. The essential diagnostic feature of matrix in cholesteatoma consists of keratinizing cytologically bland stratified squamous epithelium arranged in convoluted cyst-like formations. And the epithelium ranges from thin to atrophic, relaxed rete ridges, and shows granular cell layer with abundant keratohyalin granules. I won't go into the markers actually. CK17, KI67 have also been said as markers, and CK17 especially actually is a predictor of aggressiveness and invasive capabilities. So now let's come to the main point, classification. Over the years, there have been many attempts to classify and stage cholesteatoma, and no classification till date is foolproof. TOS proposed an autoscopic classification initially based on the site of disease origin. He divided cholesteatoma into number 1, attic, number 2, pars tensa 1, which is the marginal disease, and pars tensa 2, which is central disease. Mills and Fadgam added a fourth category to include cholesteatoma behind the intact TM, that is the intact eardrum type or the congenital cholesteatoma. In 1964, the Committee of Conservation of Hearing of the American Academy of Ophthalmology and Otolaryngology published a standard classification to guide in the surgical management. Type and location of cholesteatoma was described in gross description of the disease during surgery. Sana et al. Divided the petrous bone cholesteatoma, which is quite rare, into 5 types: supralabyrinthine, infralabyrinthine, massive labyrinthine, infralabyrinthine, apical, and beyond, extra-apical. In 1984, Lien described the CAO classification based on the extent of cholesteatoma, C, and the degree of drum atelectasis, which is A, and the amount of ossicular destruction, which is O. In 1989, Toss and Lau proposed a classification system which became very popular. This system included 3 categories. Number 1, attic cholesteatoma, which develops from the pars facida and fills the Prusak space. Number 2, tensor retraction cholesteatoma, which develops from retraction or adhesion of the entire pars tensa and involves the tympanic orifice of the eustachian tube. And third is the sinus cholesteatoma, which develops from a posterior superior retraction or perforation of the pars tensa and extends to the sinus tympani, posterior tympanum, and beyond. Toss claimed that this system was useful for selecting the surgical procedure as well as for determining the patient prognosis. Saleh and Mills proposed a classification based on the site of cholesteatoma S, ossicular damage O, and preoperative complications C. They claimed that this system reflects the severity of the disease. In 2008, the Japanese Ophthalmological Society proposed a classification system for attic cholesteatoma based on the extent of disease and the associated complications. In 2009, we had Telmisani et al., who proposed an ATM classification for classification of cholesteatoma, which included A for attic, T for tympanum, and M for mastoid based on the extent of disease. And in 2012, Belal et al. Presented a TMC classification based on the site of pathology in the tympanic cavity, T, it spread to the mastoid M, and the presence of complications C. A high correlation was observed in both the ATM and the TMC classifications in terms of otoscopic and CT findings with intraoperative surgical findings. Now we come to the Iano and the JOS classification of 2017, which is primarily based on extension and complications and aims to standardize the reporting of surgical techniques. As you could make out that all these different surgical, classifications of cholesteatoma, why did they come up? They came up because people were writing their description of the surgery, their findings in haphazard ways. There have been many studies to show that the drawings made by the different surgeons actually of the same surgery would not tally, because some were not good artists and some could not depict the things properly. So everybody felt there was a need for a proper classification, because cholesteatoma is something you need to follow up for a long time. So the Iano and JOS classification, actually Iano is the European Academy of Otology and Neurotology, and the Japanese Otolaryngology Society. It is a joint consensus statement on the definitions, classification, and the staging of middle-ear cholesteatoma. Even we, till today, I could say, often write a descriptive note about this cholesteatoma extended from the middle ear to the sinus tympani, going into the mastoid antrum. The incus is eroded, the sinus tympani was, the sigmoid sinus was exposed, etc., etc. So what we are not using a proper format. So the necessity of these different classifications is regarding the proper standardized sort of reporting, so that everybody anywhere in the world can understand what you are trying to say. And this Iano and JOS classification actually divides cholesteatoma into congenital, acquired, and unclassifiable. And the acquired can also be a retraction pocket cholesteatoma, which could be again a pars tensa cholesteatoma, a pars placida, or a combination of both. And non-retraction pocket cholesteatoma could be secondary to a TM perforation following trauma or iatrogenic causes. Retraction pocket cholesteatoma, post-surgical cholesteatoma could be a recurrence or a residual. This, the ENO and the JOS consensus statement actually divided the miliar space, which is now been referred to as the STAM system. In order to simplify the extent of cholesteatoma, the miliar and the mastoid spaces are divided into 4 sites: difficult access sites, the S, tympanic cavity T, attic A, and mastoid M. The difficult access sites are S1, as you can see in the picture, which is the supratubal recess area, also called the anterior epitympanum or protympanum, which is the area which you get after you have amputated the head of the malleus. And S2 is the sinus tympana area. The posterior border of the attic is the posterior end of the incus short process or fossa incutes. This is an important definition which has been given in this consensus statement, that the posterior border of the attic is the posterior end of the incus short process, and the mastoid includes the antrum and the mastoid cells. They staged cholesteatoma in this way. The stage 1 cholesteatoma located in the primary site. That means whether it's in the attic or in the miliar cavity or somewhere else. And stage 2 would be cholesteatoma involving 2 or more sites. Stage 3, when cholesteatoma is associated with extracranial complications or pathological conditions including facial palsy, labyrinthine fistula, post-auricular abscess, zygomatic abscess, neck abscess, etc. And stage 4 would be cholesteatoma with an intracranial complication. So the staging of the respective types could be also, it's similar, like 1 for pars flaccida cholesteatoma or attic cholesteatoma. Stage 1 is when it is localized to the attic. Stage 2 when it is involved 2 or more sites. 3 when it has extracranial complications. 4 when you have intracranial complications. Similarly, it goes for the pars densa cholesteatoma also. This is something, let me just expand and show you. They have given a lot of definitions and statements on cholesteatoma. It's very messy, but just let me read down. It's a long list. I won't read everything because I have to finish at 5. The definitions and statements on cholesteatoma. Number 1, cholesteatoma is a mass formed by keratinizing squamous epithelium in the tympanic cavity and or mastoid and subepithelial connective tissue by the progressive accumulation of keratin debris with or without a surrounding inflammatory reaction. Then number 2, they have said cholesteatoma consists of matrix, keratinizing squamous epithelium, and a perimatrix, varying thickness of the subepithelial connective tissue. Then the third, they say the pathophysiology of cholesteatoma is not completely understood. And similar lot of statements have been made in this statement. So now we come to the Cole classification. The Cole classification or the Cole classification was a multicentric sort of effort. It included one person from the BP Koirala Institute of Health Sciences in Nepal, Dharan, Nepal as well. And especially mainly Dr. Linder, Dr. Martha, Rosalie and Emmett, they are the persons who actually looked into it. So the Cole classification, there was a lot of the consensus statement that I showed you about the ENO JOS. What happened is that it has a 75 or 70% consent from the different persons who were in the consensus committee. It was not 100% approved thing. There were many people who felt that some things were not properly addressed to, and so the classification is not foolproof. And so this led to the bringing out of the Cole classification. So what is the Cole classification? This tool also calculates the cholesteatoma stage, and as you can see in this diagram, cholesteatoma extension has been shown as 0 when there is no disease, 1 when it is limited to the miliar space, number 2, 1B when it is going into the sinus tympani, I'll show you again in details. And also they address the ossicular change status. This ossicular change status is not pre-operative, it is post-operative. And the life-threatening complications, if they are present, and extracranial complications, if there are any, and also eustachian tube ventilations. Whether the tube is well ventilated, what is the condition of the mastoid. So, as you can see here, the middle ear space can be involvement of the sinus tympani. With no involvement, it is 1A. With involvement of the sinus tympani, it would be 1B. Similarly, for the middle ear, attic and antrum, up to the level of the lateral canal is 2A. If it goes beyond the lateral canal or protympanum, it's 2B. And extensive destruction is 3. So, detractors of this classification also say that here also there are certain fallacies, like they have stopped at the level of the lateral canal, have not gone beyond that. And 4A is supralabyrinthine or infralabyrinthine extension, and 4B is petrous apex cholesteatoma. Similarly, for ossicular destruction is 0 when we have an intact ossicular chain, 1 when malleus and stapes is present, incus is eroded or missing, which is commonest, and they have compared it with the Austin cartouche and fixed classifications of ossicular destruction also. 2 when malleus and footplate, etc. And so it goes on. So now, when we compare the extracranial, intracranial complications with the Iano, Jose, and the Coley classification, we see that more or less they go neck to neck, except there are certain finer things which the Coley classification has addressed. And the staging system, as we have already told you, in Coley classification, I have told you about the Iano, Jose. In Coley classification, stage 1 would be a sum of the classification values. The numbers that we have given, it is between 1 to 3, it is stage 1. It is between 4 to 8, it is stage 2. When it is stage 3, it is values over 8. So Sanchita has actually did this for me. Case 1, which she has said this is a cholesteatoma with a 2A. What is 2A? When it has gone into the sinus tympani, but it has not involved the ossicles. So ossicular number she has shown as O0, L0 because there is no extracranial involvement, and E0 means the mastoid is well pneumatized. So this gives us a total score of 2, which means it is stage 1. So that is this is a stage 1 cholesteatoma with an intact canal wall mastoidectomy. Here the patient had a cholesteatoma which had just peeped into the aditus antrum, and the ossicular chain was intact, as you can see. So this is a cholesteatoma again with 2A, similar to the first case, but ossicular destruction is there, where only the footplate is present, but the rest are okay. So this goes in, the total number is 5, so it is more than 4, so it goes into stage 2. This is a stage 2 cholesteatoma according to the Coley classification. As you can see, this is the cholesteatoma having taken now, so it is extensive, and here the ossicles, only the stapes head is present, so it is a stage 2 cholesteatoma. Similarly, the third case is a cholesteatoma with a 2B, that means it has gone to the protympanum, but without ossicular destruction. So this is the patient. You can see the chorda. You can see that the cholesteatoma has gone into the protympanum. If cholesteatoma has gone into the eustachian tube orifice, and which can be taken out easily, it still remains a 2B. And this is the eustachian tube opening which has been shown. And then this case is a CH3O1, that means, and so again it goes into 4, so it's a stage 2 cholesteatoma. Okay. So sometimes you feel that the description actually, to a certain extent, downgrades your classification. I feel it that way, at least. So now we come to this case 5, where you have ossicular destruction cholesterol, and you have a sort of contracted mastoid. So that gives us a reading of 3 plus 3 plus 2, that is 5 plus 3 is 8. So this is a stage 3 cholesteatoma. So you can see this is extensive cholesteatoma which has gone in, and and this is another one where we have a C3 O3 L1. That means there is extracranial extension, and E2. So as you can see, this is the patient which is extensive cholesteatoma which has gone infralabyrinthine. It's gone below the level of the labyrinth and has gone towards the petrous apex. And on the lower part of the screen, you can see the muscles of the neck are appearing. So it was going into the formation of a basal sepsis. So this is a cholesteatoma which will go into the stage 3 because the score is much higher. So the future, as I said, I finished at 5. The future, well, we don't know. We still don't have a perfect classifying system, but things are evolving, and hopefully we will have a better understanding of things. And let me stop my, just a minute. Let me stop my share.
Yes, Gautam.
I'm trying to stop share, but you can continue.
Okay, just a very nice, good presentation. And within a short time, you have given a very detailed one. And what is the EPI DW DW MRI? EPI means I don't know. Recent one. You have told like the EPI, DW, diffusion weighted MRI. What is the meaning of the EPI?
Let me tell you. Just give me a minute.
I don't know EPI. Okay, no problem. But
what is the meaning?
But you have nicely. But your colleague classification from is a Swiss classification. No.
Yes.
Then because I think they have revolutionized. Otherwise, they have nicely given all the points with the visual. But one thing.
I did it a little fast because I want.
No, it's okay. But I think you should present one a single paper. But one thing I want to ask, just for the clearance for the people, that you have shown that 1, 2, 3, 4 cases where your last one, the station tumor mastoid adhesion, that you have shown 0, 0. Actually, what do you mean by 0? Is it more than 50 or less than 50 like that percent?
What
and
what
it is
zero?
rated by CT scan or your operative finding?
No, it is colleague classification is based on operative findings.
No, operative mainly post-operative. The ending of the operation is your ossicles.
Non-echo planar imaging. Non-echo planar imaging.
Or non-echo planar image, EPI.
Non-EPI DW weighted images actually provide for higher resolution and thinner slices of 2 mm, which can be obtained with less false positive findings.
Yes. Okay, if Biswajit is ready, then I think we can shift to there, no?
Pukon sir. Pukon sir.
Yes, we're hearing you.
Am I audible? How is the sound,
yes,
sir?
Yes,
Sorry,
sir.
Audible. A little hiccups as always because our main OT was gynae OT was little delayed. That's why we have to shift it to OT2 XLA. Anyway, Sansita is an excellent as well, excellent presentation. Khan sir, thank you. The short notice, you have almost covered everything. So the case is ready. I think already clinical part is covered by Sansita. So Sansita is ready with the case. Sansita, can you do the diagnostic endoscopy again?
Yes, it should show the perforation. Actually, the video was not ran at the time in her presentation.
Okay. Most probably that's not linked. इसको ऑप्टिमाइज करना है हाँ ये अच्छा तो इसको देखो तुम ऑफ कर सकते हो सर no 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 stop sir sir is my the skin is visible
No,
so
yes, yes, I think it will come.
hide meeting control okay
Yes.
so there's इसको एडिट कर सकते हो उसको रिकॉर्ड में डाल दो ना रिकॉर्ड में डाल दो माइक्रोफोन दे दो
So am I audible?
Yes, yes, you are audible, Sanchita.
Yes, sir. So that time we could not suction it. So
Yeah,
now
we
I
can.
think we can see a perforation in the posterior superior quadrant of the past sensor.
Superior,
There.
superior, yes,
This
yes,
one. Let me suction it a bit more. Let's see.
yes. Left ear.
Four suction to log idea. Yeah. No, that I have cleaned already. Suction on. I've already given. I've given. Is that a perforation or is that a retraction? That's what I'm seeing. Is that a perforation or a retraction?
It's not
The
clearly
patient-
visual.
So this is not a perforation. I was thinking in the anterior quadrant, I would have got this perforation, but this one is not perforation. This part is retracted. So posteriorly, we can see a retraction pocket here. So can you appreciate?
No,
This one?
picture is not so good, Sanchita.
Picture is not
Yes, yes,
good.
yes, now it is, your section is very big.
So for me, it's actually visible. So it's not visible.
Visible, but not clear.
Okay, sir. Let me just.
microphone मेरे को दो ना
The picture is not so clear.
1 second, sir. We'll sort.
Because endoscopic picture should be clear.
Sanchita, do a saline wash.
Better now.
छोटा section दो इससे छोटा section दो tool
Yeah, so there's a retraction pocket there. I think the fundus there's a perforation. Yes. This is the retraction pocket. This is the perforation.
so what is the
Visible now? You can also
now what
suction
is the anatomy this is the anatomy now this is the anterior this is posterior then I am going
This is posterior superior, that one. Na? You show the handle of the medius, then that's the attic. So there's an attic perforation, I think.
Attic perforation is clear.
Yes, sir. This is an
I
attic
think there is no perforation in first tensa, I think.
It is retraction pocket.
retraction
Yes.
pocket.
Huge retraction pocket, but there is perforation in the attic.
मेरे को crocodile लेना एक बार crocodile दो so this is the picture
Debris are very much.
Debris are say.
Very much.
so.
This is here.
Here.
Okay.
Yes.
We can see through the perforation the head of the malleus also.
Yeah, sir.
You can
Yes.
see.
Yes.
There is perforation. The fundus is perforated.
You can censor.
Now looking at the audiometric picture
Yeah.
and this ossicular integrity, it looks very unusual. Audiometric deficit was
Exactly.
much less.
That's why I discussed with our audiologist Rosina today morning, sir. You are giving me normal hearing almost, and this child has on
Except the
radiology.
lower frequency and high frequency.
Lower and
Yeah.
higher frequency deficient.
Yeah.
Sir,
But here ossicles already destroyed. No?
as Sonsita has mentioned, most probably he has a one incision drainage long back because of post-auricular abscess.
Yes, she has told.
This is the area. This area is a little
But-
fibrotic.
But in if CT scan, that bony part was intact. I think it is already closed because it
Yeah.
was in 5 years old.
Yes.
Then
It
I'll
is
go-
now 10 years.
So I'll shift to microscope now.
Okay, good. Fine.
Microscope दो. लाइट सोर्स लेके जाओ टॉप लाइट पीछे लेके आओ ना उसको हैंडल माइक्रोस्कोप हैंडल संचिता तुम ये फला so definitely I'll not looking at the previous history I'll not go inside out way. I'll go typically outside in since he has already history of mastoid fistula. Definitely table low.
Size is also big.
So am I right, sir?
Yes.
Correct. Ekdam correct. Very correct.
मेरे को बैठने दो. Okay, nice. So first, so I think there's a lot of postgraduate today. They can interact, sir, and I have promised them to give one good software today if they have a good interaction. इसको म्यूट करना है कहाँ से आवाज आ रहा है It's okay. How is the color there, sir?
Yeah.
Okay. Color is okay.
Color is okay.
Okay. It's light. रवि साउंड देखो ना कौन सी स्पीकर से आवाज आ रहा है उसको म्यूट करो रवि प्लीज सिट देयर एंड सी ओके ठीक है so before going do you have a marker no okay चलो So I'm just marking, not making the incision. So I basically in this part, in case of this case, I'll go little bit posteriorly, about 3 to 4 centimeter behind the postauricular groove. This marking is very important for lateral closure. So already have a injected with dilafen and adrenaline, 1:2 lux ratio. So you can appreciate good avascular plane. So this,
You have injected, no?
yeah, yes, sir. Almost 20 minutes before.
20 minutes, okay.
That's why you can appreciate this avascular plane. I am almost with the knife and up to the mustard tip.
When you go through near the canal, do you feel the canal with a finger inside the canal?
सर साउंड थोड़ा बढ़ाओ ना मेरा वो स्पीकर का नहीं उसका नीचे का साउंड बढ़ाओ सर आई एम नॉट गेटिंग इट बड़ा
Yes. Do you feel the canal inside
yeah.
by introducing a finger?
yeah
Good.
we should always give a finger here so that it is protected, the canal is protected. So little up for the graph.
You'll take the graph now.
Sir, most probably I'll take the graph. I can take it later on also.
Yeah.
What do you suggest, sir?
It depends. You can take now also.
You can take now also.
If you want a wet graph to be put, then your choice. If you want a dry graph, if you take now, it saves time.
I have no such of choice. I go both. But basically in type 1 tympanoplasty, I prefer more wet graph.
Wet graph, yes, some people are going for wet graph.
But this kind of situation, I have
Yes.
no such choice.
Yes,
I can go with here dry graft also.
yeah.
But here is the graph is more important. You may require bigger graph
Bigger graph, yes, you have to take a bigger graph.
because you don't know how will be the cavity. Definitely for the this what I'm doing is for the flap. That's why
Yes.
I'm doing all this soft tissue dissection and also
Do you
obliteration.
planning for obliteration of the
Yeah.
cavity?
This is a part of the reconstruction, sir. Actually,
Yes,
I'm
because
studying surgery with the reconstruction. Because
Yes,
if you have a if you have a don't this exposure later on, then you have a problem with the muscle. Because
Yes.
suppose you have exposure here only, then you will get muscle from here to here. But if you now see the exposure from here to here, big muscle to cover obliterate the cavity.
yes, because
I
a
can
big
put-
cavity, you have to think of the obliteration now.
So that's why I
Because post-operatively, very later it will be, then peeping will be more otherwise.
let's take a graph. I take a little artificial. Hey, तुम फोकस नहीं होने से बोलना है रवि ये दोनों
I think in the middle ear also, cholesteatoma may be there because therefore hearing is, though ossicles are very little present, according to Sanchita cities, the hearing is very good. I think the transmission by the soft tissue may be there to the body. I don't know.
Have been transmitting.
Yes.
You are right.
They are not using diathermy here.
No. So you have you seen? I am not using diathermy at all.
Therefore, I am telling you. Some people start from the skin.
I am not using diathermy at all, sir.
But some people start from the skin. Skin also they do not put the knife.
Yeah, yeah. So this is my fossa.
You release some part, no release. Surrounding, I think you have released.
Release already.
I'll release more if I require, sir.
Yeah, during retraction.
Right.
Elevator done.
Okay.
Okay, so how is the picture?
It's
Picture
okay
is
now.
good.
Okay.
Very
Okay.
good. Very good picture.
Okay.
You are
Yeah.
both surgeon and the audiovisual man.
Yes, sir. So I'm trying. Let's see, sir.
Yes, that's good.
Is it adequate? It will be adequate, or you'll require more?
I think so. It will be adequate. Looks
So
like.
for elevation, this is another very good technique. If you can
Yes,
do this.
yes, we do like
Back
that.
of the knife. Yeah.
Yes, handle of the knife.
Handle of the knife.
Some people also even not inject also. But
yeah.
it's better to inject, I think.
Flap is elevated, then it becomes easier.
I'm making one incision here, sir.
Yes.
The elevator,
Yes.
done, elevator there. Elevator there. Hey, question आ रहा है क्या? Question आ रहा है क्या? झटका. Question आ रहा है.
Jhatka.
Question आ रहा है. Question आ रहा है. Elevate, sensitive, elevate. So this much of graph.
Yeah.
So I have learned it from. I can't say Satish sir. I am learning from this graphic technique from Sanjeev Jajodia.
Acha.
So they always put this incision above, so they delineate the boundary.
But you should give them to take the graph to the Sanchita because Vijayendra always gives to Santhala.
That lady. Right.
Yeah, most of the time sensitive take graphs are.
Particularly for the dry graph. Vijayendra always says she takes a nice graph. Therefore, I'll
She
not
takes
take
nice graph. She always complains.
So since we have little bit of delay, that's why. Now don't use this thumb forceps. This is a very small thing now. Don't use now. You can take a plain forceps because there's a chances of making small hole. Atraumatic. Please give it atraumatic. These are a very small thing. Sometimes
yes,
I follow.
The thumb forceps. Yes.
So already I have the boundary, sir. Can you appreciate?
Yes.
Upper boundary.
Yes.
Then
Yes.
already my 3 boundaries are open. Now you come down.
We retract this side.
Retake karo posteriorly. So that you have bigger space. Oh.
Yes. You can take a big graph.
Maybe.
Maybe. Yes.
Because you have to take the follow the graph within the mastoid area.
You can spread it up nicely.
Spread karo. आराम से.
I don't think there is bleeding.
No bleeding, sir.
You check the point corner. The corner sometimes bleeds near the
knife. So graph. Gross piece. ये क्यों खोला है?
You take this, clean the muscles, and ask Sanchita to prepare the graph.
Yeah.
You go for this other part.
Exactly.
Yeah, very correct.
The little muscle is here, sir. Just
the muscles. It is always said that temporal fascia is the always better graph. Mukherjee, you tell why?
Yes, very correct.
Why
because of the need of the nutrition is much less with the temporal
requirement of the nutrition.
Sir, why their muscle fibers should not be there?
Because it hampers with the uptake of the graph.
How, sir? How? How, sir?
No, because the muscle fiber is a separate. You are giving only one tissue. You are not giving composite graph sort of thing. Only fascia. So better there should not be any muscle fibers on it.
The middle layer of the tympanic membrane does not have so much thick muscle. Still, you can it's cleared and the graph you can it will be nice, no?
It is
because usually More cleaning in the post-operative also in
Because muscles
canoplasty.
requires more nutrition also.
There
That
is
is also
no
another
media.
point. Muscle requires more nutrition in comparison to the fascia itself. Because in any case, the graft will act as a scaffold for the epithelium to grow over it. But then it requires nutrition also to some extent.
It is
You
so
are the
immediate-
graft paper.
Neovascularization will happen.
so it is not only immediately nutrition. If it is
Nutrition,
fibers, they are over this fascia now. Fascia will remain staying like this way, but
Yes.
this muscle will not. The muscle
Correct.
starts
you will contract.
decaying property like rigor mortis
Yes,
and all
yes.
this.
Very correct. Very correct. That
So
is a
in
correct
that
point.
way, they will displayed or they will not in the required position. Ultimately, there will be micro synthesis of your fascia and all this thing. That's why
Correct.
this muscle should not be.
Included.
That's why.
You go for drilling now.
Some people do one thing. They take fascia luceria also along with the temporalis muscle. There is a supervision. There is a fascia over the temporalis fascia itself. So some people take composite along with that also. That fascia is known as fascia luceria.
I don't know.
So I'll dictate it for Sanchita, huh? That little muscle.
Yes, Sanchita, prepare. You are to late.
Sanchita will do. Nice.
So drill.
Yes.
Now I'll mostly will little bit of diathermy.
Now you use that.
Quite
You are
domestically.
using less diathermy because you are doing cochlear CI surgery,
You are supposed not to use much diathermy there.
I use more bipolar, sir.
Yes, bipolar you should use it.
Diathermy.
Surrounding tissue damage will be very less.
Collateral damage is not there.
But some people go one shot, go with them like.
Yes.
Super.
Master D.
So this is my external auditory canal, sir.
That is I'm asking. Yes.
So this is my attic, if you think. So I'll go because most of the people they don't teach this soft tissue part actually. That's why I'm for the juniors. So my attic is here, not below this line. So I'll go little bit of here where I have. So it is a coagulation mode since I'm cutting in a muscles, sir, not in a cutting mode. So this is little much of tissue and really I kept intentionally. Let's see if I go for intercanal wall, then most probably it will give me a closure.
In this case, you cannot do intercanal wall, considering that this is advanced and all.
Yes, sir.
Really? But this is too advanced.
You are using coagulation mode, no?
Yeah, sir. Mota coagulation. Mota
muscle you are cutting them.
Mota pestal beta.
Pestal level like.
No? I am going for inferiorly based flap, most probably, sir.
Yes.
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 One important thing for the pitches is that the incision, T-shaped incision, above it is at the level of the superior temporal line. So that you have taken the already EA, because that is important again.
That's here I'll go for cavity obliteration. Now this flap I am taking.
Yes. Very correct.
So it is like a U type of flap, inferiorly based. So this is a mustard tip. This much of exposure is.
Yes.
I have. मेरे को silk देना एक 30 silk dinner. So we can do this cochlear implant flap in this kind of routine ear cases actually.
Correct.
Yes, sir.
Yes, yes. That is a good habit you grow also.
Because this is the closer flap,
Yes.
flap, no, ultimately.
Yes,
You can
yes.
do posteriorly based flap, you can do inferiorly based flap, you can do superiorly based flap.
You can do superiorly based flap also.
Yeah, sir. So here required little bit of muscle. I don't think I'll come that much of here. So now, इसको पकड़ना, muscle को पकड़ो. Paste a little better. So look, sir, I am above the superior to.
Yes. See,
But this
so
will,
nicely you can see.
but this is the root of zygoma. Can you appreciate?
Yes, yes. We can
This
appreciate.
this soft tissue exposure is very much essential in this kind of case, actually, sir. Stay. Yeah. So if you go for longer detector, longer period, then always better to have a tie down than detector.
Yes. Yes.
Then a gauze piece. So this is another way of do practice for implant.
Why you put this?
So I'm not interested that much of detector, actually, master detector.
But you
So
have
you
to
see,
use.
can you appreciate how it is?
Yeah, we can appreciate. No problem.
So this is my flap. So I'll put it in. Purely, it's like
Yeah, you have to take pulvus flap. Pulvus flap.
So I'm feeling like I'm doing implant now. I'm not doing cholesteatoma.
Pulvus flap. You are supposed to give incision on the canal wall and then take the whole posterior canal wall anteriorly with a gauze piece.
Yeah.
Retract anteriorly.
Similarly, in case of if you go for this Mira and all this procedure, we do in this way. We have some clip is there. We put the clip over the flap and always go for this test, sir.
But here in mastoid, I think is not much needed. This so much stress, sir.
No, it is. You don't require retractor. That is a plus point again. You are having all everything in front of your eyes.
So just chisu, sir. Just chisu, sir. Not much.
Because it is reduced people like that. It will stay for a long time. In thyroid also, people are not, previously they have given upper three, lower three. Now it is only one. Upper one, lower one.
Just simple chisu, sir. There. That I will drill.
Vishwajit,
sir.
posterior canal elevate na korila. Posterior canal.
Elevator, micro elevator.
White is cholesteatoma.
Yes, sir.
White in a mastoid antrum position. Why white is white? Yes, on this position. I don't know.
Elevator, micro elevator.
Micro elevator help for real by canal wall skin.
Micro elevator, na. This is I needed some sharp dissection here.
Yes, because there is a suture there. So you have to be careful. Yes, you have to be careful.
Both inferiorly and superiorly.
Superiorly, anteriorly is petrotympanic suture.
Suction, madam. You can now bigger suction. You can put the bigger, not this smaller suction.
Yes, bigger suction. Yes.
Bigger suction.
Yes.
Sometimes I do with a gauze also, small gauze piece.
And after elevation, I put a gauze piece there.
Yes.
I can go to the canal also. Sorry, sir, I put this.
Yes.
Ramalingam goes from the canal, just give an incision, and then he will go from posterior again.
Yes. Put a pelvis flap. That is pelvis flap.
Anyway, I'll make an incision here. So make a 11 size knife.
Make an incision here. And yes.
And give a ribbon work. थोड़ा मेरे को और एलिवेटर देना है, एक एलिवेटर देना, माइक्रो एलिवेटर देना, थोड़ा ले लेना.
Yes. উপরে elevation করতে হবে.
I'll not go too much deeper. यहाँ पे कर देते हैं सर.
ठीक है, कोई बात नहीं. Yes.
Which 11 size blade.
Yes, yes, very correct. Now what you should do is put a gauze piece.
Gauze piece or ribbon देना,
ribbon gauze piece.
Little extend, yes.
Yes. করবো এখন. Gauze piece দিলে তো automatically everything will go up.
No, it will be tear, but it should be clean type. Then you should cartridge.
आटे फोर्स
bro.
आटे फोर्स बच्चे दो. दो नाइफ दो ना तुम काटने के लिए. कुछ यूज है ना 11 तक. बाद में कर. तो ना रिबन दे.
Yes. इधर से gauze piece देके we will take out from that side.
आया है कि नहीं? छोटा मुस्कुरा देना.
थोड़ा सा पुश करना है.
मुस्कुरा ये तो राइट एंगल है.
हाँ.
रिबन थोड़ा बड़ा हुआ है क्या? पुश it.
The child, no, his canal is smaller.
It will come. Definitely it will come.
नहीं आ रहा है सर.
नहीं आया अभी. थोड़ा सा पुश करना है. पुश लिटिल मोर. वो गया ही नहीं. देखो.
नहीं ठीक है. बड़ा होने से अच्छा है.
बड़ा होने से अच्छा है. एकदम करेक्ट.
कहाँ जाएगा यार? निकल जाएगा ना.
जाने का दूसरा जगह नहीं.
जाने का दूसरा नहीं.
Yes.
सीधा देना.
এটা আর্টারি দিয়ে রিট্রাকশন.
पेशेंट को रोटेट कर सकते हैं. पेशेंट बाहर से ना.
এত সুন্দর entire canal wall we can see so nicely. Everything is visible.
Anything you want to ask, you put the questions in a chat box.
Yes.
Queries.
Oh, also they can unmute one by one and they can ask, sir.
Yeah, there is also one by serially, otherwise overlap should not be there. A postgraduate students, any PG students, you can ask one by one. Okay.
There. Oh, circular knife दो मेरे को. थोड़ा tilting दो. मेरे तरफ से tilting दो. इस वाले घुरा दे. मुंह वाले घुरा लो. पेशेंट जन. Left. Left down. Little suction. छोटा suction. Yeah. हो जाओ. वो डिटेक्टर है ना, मास्टर डिटेक्टर है क्या? ऐसा दे. एंड्रॉइड डिटेक्टर. ये नहीं. वो एंड्रॉइड वाला.
This is one of the procedure. Actually, some people have got some detectors. One for the canal side detector, and one for the other soft tissue side. Then he will put, I think, this one now.
You okay now, sir?
Yes.
There. 11 size knife.
The cholesteatoma is coming. Yes, extend superiority. Cut in the canal skin. This side also. Yes. Correct.
Elevator.
Then separate the posterior canal. wall.
Now adrenal ball.
Some people give the incision. He is using the 10 size blade. Some people use plaster's knife. If the plaster's knife is a sharp one, then it's okay. Otherwise, a new number 10 blade is good.
Sort of bar.
Now separating the posterior canal wall. See? Nicely.
Bar lagao.
With a
Bar lagao.
circular knife. To hold.
Vishwajit,
Yeah, sir.
I feel you cannot approach to the apex of the retraction pocket from this side.
Yeah.
So
Yeah,
I
yeah.
think you have done maximum what is supposed to be done. Now you open through the mastoid now.
Yeah.
Because through the mastoid you are supposed to go now.
I'll definitely go to the master.
No, they will go through the mastoid, but you have to raise the canal skin.
No, he has raised,
Okay.
but thing is that you cannot go to the apex of the retraction pocket.
No,
It will
that's
be
a different
quite
thing.
deep. It will be quite deep.
So can you appreciate how the picture there? I don't know.
Yeah.
I can appreciate. Nicely.
Nitya sir want to say that he find focus, please. Find focus. Oh, now
No.
focusing is good. Nitya sir. Nitya sir, also you are master, you can ask question. You are there. Very
Yes,
good.
sir. Now the focus is really good now.
Oh, your focus is good. Teacher sometimes forgets, no?
मेरे को बाहर होना थोड़ा. I'll do canaloplasty little bit.
Yes,
Adrenal
canaloplasty
ball
is good.
इरिगेशन क्यों नहीं लगाया इसमें? एक सलाइन लगाओ ना. अभी दे दो, बाद में लगाओ ना.
This canal is dead or what? You want to do canaloplasty?
पानी. बोलते रहो यार, तुम इंटरेक्ट करो. I am doing further. I am
Sir,
doing
do you
audio visual.
sir do you use something to protect the flare from going into the the shaft of the bird?
Yes.
Yeah. I can use the gloves.
Because personally I always prefer that, because I have burned some of my fingers trying to be a little bit casual in that state.
Yes.
Yeah. You can give me adrenaline one. Give me one adrenaline wall. Let's see. Yeah, Nitya, you are right. Always better to keep one here, so that your diamond, that means the external skin.
Why you want to do canaloplasty here?
So I want to go.
You will learn like that or what?
Sir, are you planning a canal wall down or a canal wall up?
It
I
will
don't
be
know.
canal wall down. I am sure of it.
Then
But only
canaloplasty
thing-
is not needed.
Okay. Don't waste time. See, chalo.
No, it is better to have a better view, nothing else. For a better
Exactly,
view.
sir. I want to see at least through the canal as much as. And
For
if I
better
can
view,
go,
nothing else.
my intention was
Sinus
little bit of
thin,
conservative. If I can go little.
Yes, very correct. To make the canal papery thin, so that
Exactly.
ultimately, yes,
So that's what I have the intention. Anyway,
I understand your feeling.
so that I can reconstruct.
Sir, so you are planning an inside-out approach, sir?
No. I'll go.
Outside in, I think.
Outside in.
Outside
not
in.
inside in.
Okay.
Funny, huh? ठीक है एड्रेनलिन बॉल देके रखो कैनल में एड्रेनलिन बॉल रखो ना
Cholesteatoma ulayas.
पानी और इरिगेशन नहीं लगा है यहाँ पे मेरे को बड़ा सेक्शन दो you can bigger section.
Itu na putuli ডাঙৰ series লৈ লাগে বহুত লাগিব ডাঙৰ series
What is the bird size, Biswa?
Money, Sanchita.
Biswa,
Sorry.
what is the bird size, Keshav?
Oh, it is 2 mm. I can take bigger one. हो गया ना केशव देखो ना
পানি পানি
पानी पानी पानी
Yours is a smaller bird.
it is new, that's why I'm taking this. You are मैंने भटकते धोइला ना then my bigger was become so ये भी नहीं कर रहे हो order ना दूसरा order
Bishop, you show the marking line for the junior, your from where to start drilling.
exactly sir
And
this
your
is the
if you have got the handless spine or any
this is the spine of Henley
support
side. Can you
place.
appreciate this is the spine of Henley? So I
Yes,
have started like this is the first cut, then I have cut second cut, then this may be the third cut.
yes, like this,
So,
yes.
but since it has a stage 3 disease, so I am already the big. Can you appreciate the cholesteatoma here?
Yes, yes, it is easy becomes auto done.
A good case for the this kind of now. मेरे को अच्छा बार दो साइड से जो करते हैं and always the juniors always cut with the side of the bar. Anyhow manipulate your bar so that it does not don't do drilling like this and always by one motion. If you don't do like this way, it's always better to cut like this way from right to left. Cutting border. Give me bigger cutting one night time later. Irrigation आ गया? लेना irrigation ले. किसे लगाएगा इसमें? कौन बंद करो? Sanchita पानी डालो. Still, I am not keeping my external canal wall intact. Mukherjee sir. Oh, Nitesh sir,
Yes, boss.
can you do intake canal wall and do reconstruction of?
Yes, we can do intake canal wall, we can do reconstruction. But it also depends on how extensive the cholesteatoma is, how bad it is, how much the granulation tissue, how easily we can separate, what is the extent of cholesteatoma, where is the primary site of involvement. All these things will come into play.
That means if you put a intake canal wall intake, then it interiorizes the whole, the principle of interiorization, no? बहुत काम हो रहा है एमपी दूसरा हैंड पीस देना वो हैंड पीस देना बहुत काम हो रहा है ये बहुत ठंडा ठंडा करो ना दूसरा बार दो
Sanchita is assisting you, no?
Yes sir.
Abhisha?
Sorry.
Sanchita is assisting you.
Yeah sir.
What is the Sanchita What is the stage according to Cody classification? This case, you cannot detect now. It will be afterward, post-operatively, no?
Yes, sir. Yes, sir.
But your radiology, something you can detect, though CT cannot, more sensitive, but specificity is less.
So how is the video there?
Video is good.
Okay, you
So in this way, you can palpate how much I can go superiorly. If I put my suction here, then this much of part I can go.
CT has given, though CT has given a little roadmap, still you should be careful, no?
Yeah.
And he's using his bar from below upwards,
Yes,
not
sir.
going above downwards, above
Yes,
the
sir.
deep. During this segment, tympani
Yes.
must enter.
पानी नीचे यहाँ पे पैड रखो बहुत पानी गिर रहा है कंसीडर वो कैमरा बाहर का कैमरा फोकस करना है
Probably bring it a bit down. Bring it up.
So I'm about to reach at the level of the enterocardiac wall.
Yes.
So intentionally I'm keeping the external part of the external auditory canal. I'm not doing canal wall down procedure. Because if today's with the equipment like high definition camera and all these things, there's a less chances of, I think, if you can go every corner of the middle ear cleft.
Yes.
Less,
You have
less
got
chances of-
endoscope also. Then you
yes,
check.
sir, that's-
You check it. Therefore, you are
So-
doing thinning and thinning more.
maybe later on I have to canal wall down.
Yes.
But intentionally I'm keeping the canal wall, and that's how I'm doing practice also. So this is the thing you can do practice also. Yes, seriously, sir. When I do practice in harm,
Canal wall up.
yeah, canal wall up, exactly, sir. So I always do. I know this case required canal wall down procedure, but still I do the thinning of the posterior canal wall, do the posterior tympanotomy, then I will go.
But
That way-
you were, therefore you have become a CI surgeon.
So it's not like that this patient को canal wall down करना है फटाफट आके canal wall down करो. But you can do intercanal wall, then do posterior tympanotomy, then go for canal wall down.
Yes, you can do later also. This guy thinking.
Exactly, boss. For me also, I always prefer canal wall up, and then if I can't do it, then only I go for canal wall down.
Right.
My first priority is always try to do a conservative approach.
Yes.
Yeah. Funny.
In our days, after MS examination, there is no canal up technique, always canal down.
Yes.
Because there
Even
is
even what I heard
no
is
microscope.
Mohan Kameswaran also prefers canal wall down all the time, most of the time. I heard like that.
Yeah, maybe, I think, no. But he is also good CI surgeon, but he should not actually, no?
Exactly. So again, it also depends on the experience.
Yes, yes, the experience.
So I have seen no ossicles. If I've seen ossicles, then my first job should be dislocate the IS joint, then do the drilling here. Again, it is, sir. Am I right?
Sorry, sir. Sorry, sir. Once again.
Since I have not seen, my intention to see here elevating the flap, the continuity of the ossicles. In the interossicular sign, we should not drill like this way.
Yes.
First, your
We
first
should always be careful when not to hit the ossicles at all costs.
Yeah. Because you look, this is a mild conductive loss. Yeah, I have discussed with Rosina today morning. Why are you giving this case a mild conductive loss? ये तो बहुत loss होने वाला है अभी.
That is the main problem. Hearing is mild. Is 10 years boy.
But again, sir, we have to counsel them beforehand. We have to tell them what is the possible cause of conductive hearing loss after. Because whatever or whichever ossiculoplasty we perform can never be equal to what God has made for us.
Yeah.
No, I have seen some cases doing ossiculoplasty by big surgeon. When you see the patient, you do an audiogram, all loss is there.
Exactly. There is
I
nothing
don't
like
believe
there won't
that
be.
I am doing ossiculoplasty this type 2, type 3. Only some rare cases. Otherwise, I've seen not a good one or people.
Especially in cholesteatoma, which is already engulfing the ossicle. How can we leave the ossicle? There's no way around. We can remove the ossicle. We can prepare the ossicle or keep the ossicle.
Yes.
Better for me, what I prefer is I prefer to sacrifice some part of the hearing rather than waiting for complication to happen.
Yes, that is correct. In cholesteatoma, it is the motto. And moreover, this case, CT scan as sensitized so that there is no ossicle actually. Only small shadow, something like ossicles are there. Still the hearing is, and it is only some low frequency and only little high frequency loss. Mid frequency almost normal.
There is also a case of cholesteatoma hearing, no sir?
Yes. That is the, I think. Moreover, depending upon the intelligence of the boy, 10 years old boy, you cannot much rely some 10 decibels, 20 decibels.
Sir.
Sorry, sigma period was 0 according to Sansita. I don't know. Okay. Where? What about the facial nerve? You have mentioned that the facial nerve is little.
The essence was not there.
So, can I go for the cholesteatoma removal? Let's see the cavity. The elevator the suction block. Micro elevator. Wow. There is no canal from here.
All auto mastectomy has been done by the cholesteatoma.
Yes, sir.
Only your posterior canal is hanging only.
Sir?
Sir, in such case, is it still preferable to keep that ledge of bone of the mastoid cortex? Because the medial part is already gone. Why not just remove it and open it up?
Which one?
We can always reconstruct later on.
I'm not getting it, sir. You want to remove this?
No, he doesn't want to remove.
Yeah, I mean, there is no role of putting a small ledge of bone over there.
Yes, there is no.
This was.
It only hinders the visualization. That's the one.
Okay. That's why I'm thinking
Because
also.
more than half of the middle part is already gone, sir.
Gone,
Yeah,
gone.
yeah.
Cholesteatoma has taken all this check.
Yes.
The सबका permission लेके sir classical canal wall down now.
No, you have to do nothing, only one, just hanging this part.
But still, Nitesh sir, Nitesh sir.
Sir,
Can I give a
see,
support?
only the lateral part is there. Middle part is all gone.
I know your point. Support. If you can give a support from here to here, can it be possible?
Boss, my opinion is if we want to do a such case with this much of bone destruction, I would prefer a canal wall down. And if I still want to do interiorization, then I would reconstruct the canal wall with the cartilage later on.
Kudus Ahmed is commenting, there is a radical mastectomy. Yeah, correct. This is always we read like that. How the hearing is so much good, I don't know.
कौन सा है क्या? कौन सा है?
नहीं, मुखर्जी बोल के को बात. मुखर्जी बोला.
Sir, without going down too much towards the inferior side, if we remove this ledge of that bone only in the upper and middle part. Yes, you are removed.
Yeah.
But not going very down. That way we will have that the inferior part of the canal wall, which can serve as a foundation for the canal wall to during reconstruction.
ठीक है मान लिया.
ये कुछ भी नहीं है. Nothing is there. Now you can do a audiogram. Take the hearing. बत्तीस को डाउन कर दो, कुछ लाभ नहीं.
Against the bridge of bone, have you seen?
Yes.
The last bridge of bone.
Yes.
This is antibiotic. Suction block. Suction कम करना है. दे साफ करो एक बार. कोलेस्टोमा को रिमूव करते हैं. नीचे से क्या है?
कोडो क्या करें?
Yeah. That's why I want to remove that. Or irrigation, sensitive irrigation. जाना एलिवेटर है. अभी जो एलिवेटर दिया था वो एलिवेटर है. बॉल को बता दीजिए. बॉल बता दीजिए.
Mister, is this your microscope a varioscope?
Yes, sir.
Oh, that's why it's auto-focusing, huh?
Yeah. How's the quality, sir?
Very good. You're having auto-focusing, so you don't need to.
Yeah. We can adjust from any place. Nowadays, most of the high-end microscope are varioscope. It does not require different lens for larynx, different lens for ear surgery, like that. Can you see the matrix of the cholestoma? Can you appreciate?
This part is going behind.
Yes, very much.
Yeah. Like a little. So, according to Sansita, this is the stage 3 disease.
Huh?
Yeah. And this is a facial canal, I think. Just a transit patient. Thank you.
After that, focus on the picture.
Thank you.
Nice. A full matrix.
This is a whole small whole mastoid part, sir. Yeah. Like this.
Now you can probably zoom in the picture.
बोल देना आइडियल बोल देना.
It is radical master.
Yeah.
You
Sir,
down
when
the
we have
port-
removed in such a way,
Yeah.
now we need to see whether the real sec is left behind or not, or whether it's just the matrix which has been removed.
Yeah. How can you know? But is it
Sir,
removed whole sac is
if
removed?
we have the high magnification, we can know about it.
It is how much? The magnification is high almost, I think. How much is the
Sir,
This
magnification?
is low magnification, sir.
Sir, can you what Nitesh is saying? Can you what the Nitesh is saying? This is you appreciate. You can appreciate here.
You have some
Yeah,
metrics there.
yeah. So you have it. Can you see?
Hmm.
Yes, that's the sec. That's the real wall.
That's the real one.
No, you
I
have
have
to
removed from
remove it.
here.
Exactly.
I have removed from here. Adenine
Slowly,
बोल देना.
slowly you remove it.
Adenine बोल दो.
Like Vijayendra, yes. Very good. Vijayendra always do this. Nice.
Okay, Nitesh sir.
Yes.
True capsule or false capsule?
Now the true capsule is removing.
Like thyroid.
Now I'll go to middle here. So suction अभी छोटा सा है. This is I think corda.
Where?
Nitesh sir, this is corda.
Yes, yes.
Can you appreciate the corda?
Yes. More magnification, he said.
Can you appreciate the corda?
Yes, we have seen it in the other.
Then हाँ sir.
Yes, yes. This one.
मेरे को वो छोटा section. I am in the high magnification, sir.
Yes.
Yes.
It's a Vincent magnification. Robert Vincent magnification.
In this microscope, is there any criteria that it is how much it is 15 or something like that?
Yes, sir. Yes, sir.
It is 15.
It is. Let's say.
Sir, how often are you able to save the corda in such cases?
Yes. Usually gone.
Crocodile. And this is the only ossicle, I think, ossicular part she can appreciate in a CT scan.
Yes. Sanchita nicely showed that part.
Can you appreciate the head of the malleus? Only the head of the
Malleus.
malleus.
But it is going, corda is going.
Elevator. Sorry?
Corda is going which direction? Malleus is down over.
That is hardly the head.
No,
Then
corda
not-
always goes under the malleus, sir.
Under the malleus, but it's shown that over the under the.
Sir, I'll explain
So
the
the anterior part has not been exposed
Yeah,
properly,
Yes.
clearly at the moment. That's why.
Not clear shown.
Sir, I'm going to remove the as Nitesh has advised the set from the epithelium. Yeah.
Yes, that's nice.
No, you will remove it. Okay.
Sota
You have to remove.
Antigen for smaller one.
You have to polish the mustard cavity. Polishing after that.
Yeah.
Polishing bar like Vijendra.
So can you appreciate this going
Yes,
to
yes.
supertuberculosis?
Yes.
Am I right, Nitesh?
Yes, we are going towards the
Can you
anterior
rotate,
epithelium.
can you rotate the patient bed towards Ravi? थोड़ा एडिनल बोल रहे
तुम कर सकते हैं bed पे.
बेड उधर धीरे से हाँ नॉट टू फास्ट
Here, there's some bed. See, bed पे.
वो लोग कहाँ गया
इधर नहीं था. Remote ready. धीरे-धीरे, हाँ, आप
गिर जाएगा पेशेंट
left down, right down.
एडिनल बहुत छोटा है ये सक्शन में ब्लॉक हुआ
Right down.
सक्शन में ब्लॉक हो दूसरा सक्शन में
Right down.
ये लोग को बुलाओ ना कहाँ गया तुम बुलाओ ना रवि पच्चीस गिर जाएगा
Call someone.
ये सब
What
दो काम
happened?
तुम्हारा जो नहीं सर आई वांट टू रोटेट द बेड लिटिल बिट टुवर्ड्स राइट एक्चुअली सो दैट वी कैन अप्रिशिएट द स्टेशन ट्यूब एरिया तुम कहाँ जा रहे हो
Dr. Sayantan Rudrapal has commented, very informative live session. Amazed.
Oh, hopefully she is from GMC. You can unmute yourself and
Yes, you
comment.
can talk. You can unmute because there is no much participant, and you can give comment or something controversy. You want to ask, you can ask nicely.
No. I'll do the
It's
centralized.
free for all, actually. And the surgeon is always free for all. Vishwajit Goel.
Sir, I'll do little removal of this breeze part. No, this is not the ideal bone. Yes, so then you can appreciate the supratival area.
Anterior buttress.
Yes, we can see.
छोटा नहीं इतना छोटा नहीं मतलब ये ले लो if you have I can go to endoscope also but doesn't require
Microscope is better. Sir.
yeah
So you're taking down the anterior buttress.
Anterior buttress, yes. Correct, Guruji. To the anterior space.
but okay now see it is going now.
So can you see the anterior wall of the
Yes.
attic?
Sir,
Can you see the anterior wall of the attic?
anterior.
Wall. Anterior limit, that means.
This is the anterior limit, sir.
Yeah, anterior limit.
Yeah.
Can you probe that
So
area and show?
we still need to
the-
remove some of the anterior buttress.
Yeah, this
Yeah.
one.
This one, no?
Yeah, this one, yes. Overhang.
I'll do.
Slowly.
See, first, can you appreciate it is going
Going above. only.
Lovely. Very lovely.
what indication?
It's very nice. Very nice.
I think this is the apex. I am coming back from the apex.
Sir,
Overhang is there.
can you turn the head little bit more?
A little towards right. Little towards right till.
Yeah. Turn the head or the back little more.
Little more I can or another I have to deal more.
Right down.
Then we will be able to see the whole of that area.
Endoscope. No, ulta.
The other side. Arulama?
Bus. Now,
I think centralized little bit, sir. Yes, in a much better version. Then we will be able to appreciate the facial nerve also very, very nicely here.
yeah. Okay, Nitu sir.
Yes, lovely.
Now I'm coming back.
So basically, you are leaving behind the mucosa and removing only the sac.
Yeah.
This is what I can appreciate from here.
So this is the head of the malleus. This is how this was your cholestoma. I'm repositioning the cholestoma again. Then I'm again taking back. So this is so if you don't remove, suppose if there's intact ossicles, if you don't remove, you can't remove this part of your cholestoma. Am I right, Nitesha?
Correct.
So don't hesitate to remove the ossicles. So this is the, I'll go a little bit of low magnification now. Now I am coming back to, yeah, ये bone किस लिए रखा था हम लोग? Suction गिर गया. Suction गिर गया. Suction नहीं है. मैं फोन किसका है? देखो ना. रवि. हाँ. किसका? और कौन सा ऑपरेशन को जैसे भी सकते हैं? So this is not cholestoma, no? This is your flap. But I just see that, but I think this is not a good, healthy, Nitesha. Fukan sir.
Yes, boss.
Should I remove this portion? Or this is a good mucosa, external canal skin? What is your comment?
Sir, I think it's better to remove because it is attached with the mucosa so nicely. I mean, like there is no clear-cut way to separate it.
Yeah.
There are islands of matrix stuck to the undersurface, inner
So
surface.
are you see that, Donna? Yeah, and the tip of the malleus, huh?
Yeah.
I have also seen.
Because sometimes congenital cholestoma comes as just a purge.
So I'll remove this portion, okay? Nitesha, should I start from here?
No way. I mean, like you can go still up because the canal skin is still there. It looks healthy.
So from here, now?
Yes.
From here, now?
Yes.
Okay.
Yes. Lovely.
So it will be my lower flap. Okay.
Yes, we preserve the canal skin now.
So now you have this thing. So it is above the malleus. So let's keep the malleus. And I'll, yeah, वो दूसरा एक आगे सीधा है ना? Okay.
Yep.
Shall I?
Those were going to see.
ठीक है ना, Nitesha?
Yes, yes, yes.
There. Okay.
Can you show us the landmarks, Bishop?
Sir,
Yes,
This
the
is
Show us,
Orient.
show us
Orient
the
is
landmarks,
landmark.
the facial nerve,
sir, just a
the
minute.
processors.
Okay, I'll show you. I'll show everything. Nikalo na.
Sir, if you remove the bone prominence over the
Yeah.
the pyramid. No, little above.
Diamond.
That would expose the whole of the oval window area.
Diamond. Yeah. No. Short diamond. And this good.
Bishop,
And sir,
for the benefit of the viewers, you just orient.
okay, just give me some minute. This is what Nitya say. Can you appreciate this is the
Yes.
portion of the inferior posterior canal wall?
Yes.
Okay.
Posterior
Yeah,
buttress.
Yeah, you can actually it is not posterior buttress. Posterior buttress is here, sir. There's a breeze here which communicate. This is the anterior buttress, and you will get the posterior buttress here. Actually, this is the just inferior portion of your posterior
Canal wall.
Yeah. So I'll go in. I can say this maybe the posterior buttress. It will be.
Oh, that looks
Yeah,
like.
absolutely.
So I'm going to remove, and this is the facial nerve, sir. This is the second genu, and this is the horizontal portion of the facial nerve. This is the head of the malleus. This is the remnant tympanic membrane, pars tensor. Okay, sir. And you can appreciate chorda tympani here.
Yes.
Still there is a cholesteatoma in the mesotympanum and hypotympanum.
Exactly. Just for that only, I wanted that bone prominence to be removed.
Yes. Correct. Down it.
So how much you can remove? You can appreciate this. You can remove till here.
You are using diamond bar now?
Yeah, sir.
Then irrigate
Yes.
more. You tell this thing because they are observing, no?
Yeah.
Why you use diamond bar and how much irrigation is necessary.
Yeah.
And watch the movement of the bar.
Movement of the bar, direction of the bar, long handle, short handle.
And the side of the bar cutting.
Yes.
So along with you need a very good microscope and good magnification.
Huh?
So along with that, you need a very good microscope and magnification.
Yes. That is the most important instruments and gadgets.
And like with the what I am dealing, sir, I am dealing from superior to inferior, the same line of the vertical portion of the facial nerve.
Yes.
I'm not doing like this way. And every stroke you observe how much bone you have removed.
Change of color.
Change of color, any bleeding vessel.
More irrigation. Irrigation should be continuous here. Now. Because you tell the temperature is more reachable by the diamond bar.
That's why we are taking nowadays cutting bar in case of posterior tympanotomy rather than going for a. Then अभी मेरे को elevator ने तो ball कुछ नहीं तो हम थोड़ा इसको down करेगा हाँ तुम्हारा ये bone.
Yes.
इसको obstruct कर रहा है मेरा vision.
Because if you are not planning to reconstruct, then you can take it down completely.
Yeah, exactly. यार इसको क्यों रख रहे हैं हम? Reconstruction.
If planning for reconstruction, then you can keep it.
ठीक है चलो double minded man.
Maybe sir, Gautam is coming. I'll leaving you. I'll see through the observe through my mobile. Okay. Thank you very much.
Sir. Thank you, sir. Please continue.
I'll continue. I'll continue. Don't worry. Neeraj sir, you
Sir,
do
sir.
that. Hey, you do. You stay there. Okay.
Flag bearer को आप छोड़ के जा रहे हो सर.
करेगा.
आप भी दो ना मेरे को वो दे बॉल प्रूफ दे कुछ दे माइक्रो एलिवेटर दो. तो ठीक है अभी ठीक है. I am going for cholesterol removal from nego team Benam.
Where is your Corda, Mr.?
Sir.
Corda?
Just a minute.
Is your Corda still there?
Yeah, sir. I'll show you the Corda.
Sir, positive part is still intact. I don't know about the anterior part.
Micro elevator. Yeah.
Yes. But
Can you appreciate the Corda, sir?
Yes, there's cholesteatoma underneath it.
So your disease in the.
Sir, we still need to remove that. We still need to remove that bone. We are going blind. We still need to remove that.
You want to remove this portion of bone, huh?
Yes.
Posterior buttress.
There. Pani sensitive irrigation. Bed to hilai second by. Bed to kunda hilai. Bed to kunda hilai se bolo. थोड़ा पानी कम दो थोड़ा कम दो Meter sir, okay.
Sir, little downwards, yes.
Yeah, elevator dena.
You can clean that area and see whether you can reach that cholesteatoma matrix.
I think now we can reach.
Still, I'll do.
Sir, are you going to preserve the Corda?
Write down. Write down.
Are you going to preserve the Corda?
Ulta.
Right, side down. Down. Roba.
Are you turning the head? So.
No, the table. The OT table.
Table, not the head. Nowadays, we don't remove do movement to the head. Because this these tables are OT tables are we can rotate so that we can.
सर वो कोडा के जगह को थोड़ा और ड्रिल कर दो.
कल आ रहा हूँ तुमको मैं एंडोस्कोप से मैं लेके आ रहा हूँ रुको. बापा रे की बढ़िया दिखाई दे. अभी देना एंडोस्कोप देना मेरे को. एंडोस्कोप देना. एंडोस्कोप दे बढ़िया बस सामान बढ़िया लाइट टेबल दे. दे कैमरा 0 डिग्री. विशेष है तो इसको विशेष है. तो मेरा पिछला हेडलाइट नहीं है क्या?
हेडलाइट तो डिबो लगे सिला.
पिछले हेडलाइट तो रखे अभी.
हेडलाइट तो पिछला पर फोकस करिए.
कुछ अभी तो नहीं गए अभी लाइट तो किया दिया ना. Light brown. Suction.
It's okay.
Ravi, how's the picture? Ravi, Nitesh, how's the picture?
सर थोड़ा सा फाइन फोकस चाहिए.
मैं को दे रहा हूँ. देना मेरे को एलिवेटर दे. Now what I am using now. एक बोल देना. हो जाओ. अभी के लिए नहीं सही था, मेरे को बाद के लिए सही है.
So can you just explain why you're using the endoscope and what you are doing right now for the PGs?
There is some disease in the sinus tympani. I am
Can
not
you show the
interested.
sinus tympani? Can you show us the sinus tympani so that
Because
we understand
what
where you are?
Nitesh is requesting me, can you appreciate this is the chorda tympani? So chorda tympani is thus originating from here. This is the vertical portion of the facial nerve. Okay, this is the second geno. This is the supratibial area. This is the first geno. Can you appreciate? This is the first geno. There is erosion by cholesteatoma here. So this is the vertical portion of the facial nerve, and you can appreciate the head of the malleus here. This is the chorda tympani. This is the chorda tympani. So if I am doing blindly here, that's why Nitesh is asking me to down this portion of the bone. But rather than going for down with the drilling, so why I don't take this angle scope? This is not a nowadays all the 0 degree scope or wide angle scope. So
at the first genu, can you see the cochlear processes cochlear formation?
Definitely. Can you appreciate a glue from the sinus tympani area?
Yes.
Can you appreciate the glue from the sinus tympani area?
Yes, we can. Very clear.
So I am not a visit surgeon. I'm not only the microscopic. I don't prefer only microscope. I always go with the instrument base for the base area actually. Sometimes I didn't बोल डालना इसमें. पेशेंट आई से नहीं गई. प्रांजित सर का कौन है? So this, can you appreciate the round window, sir?
The round window, yeah, the prominence, yes, very good.
Can you appreciate the round window? So this is a promontory area, but you can appreciate the
Sir,
whole
your
part.
endoscope is not fine focused. Yeah, the endoscope picture is not very fine focused.
Maybe
And little section will be really helpful.
Wash and suck.
But Nitesh, we are focused here. Let's check your internet connectivity. Because when there is a poor internet connectivity, sometimes you have a not good resolution. Let's check one.
But the Egbar section, we please section it once.
Definitely, I'll do suction.
Yes, and another thing is there is a curve section for endoscopic users. If you have that, it really helps.
Yeah. We make all these normal suction curves sometimes, but Now can you appreciate the round window area? Now you see the disease in the sinus tympani.
No disease.
Can you appreciate, Ravi?
Yes.
Yeah, Ravi nikala hai.
Ravi.
Nitesh sir.
Ravi Niteshwar.
Nitesh sir.
Sir.
एक मिनट ना यार ड्राई बोल देना ड्राई नहीं तो एब्जेल दो
Ah.
ड्राई दे हेलो पानी में दिया हाँ crocodile हाँ संसिता now can you have you seen the matrix here with the endoscope Nitesh sir in the mastoid
Yes, boss. Yes.
हो जाओ don't give water now I am interested to lift this area.
Boss, if you have 45-degree endoscope, again that will be much better, either a 30-degree or a 45-degree endoscope.
There's the facial. Now, कॉर्डा चला गया ना? कॉर्डा तो जाना ही पड़ेगा.
You were trying so hard to save it.
हाँ, नहीं वो हैंगिंग के लिए हो यार. कभी का ऑसिकल्स. इसको निकाल लेते हैं ना क्या ये सब टिश्यू को?
Yeah, why to keep? Yeah.
Yeah, the cup portion ना. So total portion नहीं the cup portion. Actually, this is the fallacy of my endoscope because look, my control of my hand is not good.
Exactly.
When I do single-handedly, na. When I was in microscope, my chorda was safe. But when I convert to endoscope, my manipulation, magnification, everything matters, na.
Yes.
That's how endoscope is a very good tool for visualization, but not a good tool for
Operating.
operate, sir. This is my feeling, huh?
You don't use Hazarika's stand.
Can you appreciate like this kind of part? Still there is some squamous remnant is there. Now I'll go this direction. That is the station tube area. Can you appreciate the station tube area, sir?
Not well.
Give me the elevator. Give me the elevator. No, I'm not because I'll. Oh, I already it is there. It's there. There. Can you appreciate the station tube area, sir?
Ah, yes.
Okay, sir.
Yes.
Yes, boss. Yes, very nice.
So as such, no cholesteatoma. This is your matrix again here.
Bishop.
Sir.
Hey, can you show the participants where your
This is your professor's coliformis. This is. This is your professor's coliformis, sir.
And what is that hole in the coliformis?
It is one of the tensor tibia tendon attached here. Also the mark for the horizontal portion of the facial nerve. Can you appreciate the horizontal portion of the facial nerve? It is over the horizontal portion.
Facial nerve descent?
Sansita has one area where there is a facial nerve is dehiscent.
No, the one we are seeing there straight away posterior to the cochlear. Posterior cochleariformis.
Sir, no. Okay. So where is the veil window, Nitesh?
Where is the facial nerve? I mean, that's the one. No, anterior. The superior one, superior. That's superior. Just superior to where you were doing.
Adenal wall. Yeah.
Because it was just below the lateral semicircular canal. So that's the lateral semicircular canal bulge. It's below the, yeah, it's very deep.
This white area is the facial nerve.
Yeah, that white area is facial now. I know.
Yeah. Is it decent?
It looks like it looks like exposed.
Yeah.
So I'm keeping adenal wall here, okay, for a few minutes. So next, okay, as far as I have endoscopical, I have seen every nook and corners. So it's no disease at all. Nitesa, are you happy with the disease removal, or should I do more?
Yeah, I think it's okay. I just want to see the final part in the root of the Koda.
Recording stop on. So I'm putting adenal wall in the oval in the area. I'll come back again on that area. Let's do little work on the. Should I go for canal wall, reconstruction of the posterior canal wall, or obliteration, cavity obliteration? Cutlass. I'll go for cutlass now. I'll do little work here. I have seen some remnant. Give me some. Focus on that. So इसको ठीक होना समझा. मुझे डील दे डायमंड डील हो जो भी डील हो डांगा दे मत তুমি তো কইলছুন ডাঙা এটো দে irrigation ডাঙা section
Before the participants would like to see where your lateral semicircular canal bulges.
Yeah. Let me focus, huh? Yeah, why I'm double vision. It is sometimes very difficult to adjust after doing endoscopy and again microscope. So, sir, this is the second genu. Can you appreciate the second genu here? This is the second genu area. So, this is the bulge of the lateral semicircular canal. So, it is editas of the antrum. This is dura. This is the antral part, segment antri. Okay. And this is a segment tympani. This is a segment empire. This is a mastoid.
Segment antri.
So this is the bulge. Am I right? This is the bulge of the lateral semicircular canal.
Where will be the fossa into this?
So it is not now because we have removed the.
Yes, but where is the position?
So here, because the short process of incus will be here in the fossa incudis. Funny.
So now you're polishing the walls?
Little bit of, I have seen some cholesteatoma circ. I am putting a diamond bar and I am going for suction block. Bada suction dena. Yaki dangor kita nai ni master deal kote hodai dangor suction deal.
There is a controversy regarding the use of a cutting burr and a diamond burr when you are trying to remove cholesteatoma from blind areas like that.
Yeah, exactly.
Some people say cutting is better. Some people say diamond is better. Some people say diamond will embed the epithelium inside of the crevices of the bone. Some people say cutting is better because it doesn't embed the epithelium there. What's your take, boss?
So since I'm going for external the cavity, so I'm little bit of polishing the snow as the ventilated mucosa.
What is your take, Niteshwar?
Sir, if it's not very near to the very important structures, then I prefer cutting. And rather in out of that cutting, not the coarse cutting burr, but the polishing burr. That is better for us. But if you are very near to the important structure, then definitely diamond is the one.
क्या करो नितेश साहब बोलो अभी last comment. Should I remove this?
Boss, if you are doing a canal wall down, then you have to remove that.
Okay.
You have to remove that.
Yes.
Oh, no, Mokhaji sir, good morning.
Good evening, good evening.
I know you are not there and again coming back, so I'm telling good morning.
No. Tika, it's okay. But I think that portion has to be removed because you have to see the structure underneath also.
Sir, are you using diamond or a cutting?
Hey,
Diamond, I am not changing. I can use cutting also, but
Yeah, you can use cutting.
in Sambo, there is a word called think tank deformity now. You can ask any PG sir, what is that deformity?
Sorry, I couldn't hear it.
Think tank deformity.
What deformity?
What was that word? Biso?
Haji sir, please. मैंने क्या बोला?
What was that word?
What deformity? I couldn't make out.
You have nicely done this whole canaloplasty. Disease has been cleared nicely.
Thank you, sir.
Disease has been cleared nicely. That is true.
Think tank deformity means. Good, you should give a good cutting, right?
And the movement of the burr from medial to lateral, isn't it? So that you don't accidentally injure structures lying medial to.
Focus मेरा पे है, इसको तुम करो, तुम करो ना, ये. And also your age of this thing.
Yes.
Age of the mastoid cavity should be well smooth so that muscle grows inside.
That's why Bisho, better to use it contra angle piece.
Yes.
Contra angle piece is important. So that teeth is visible to you.
I have finished almost the mastoid work. I don't know. क्या हो रहा है ये खुल क्यों जा रहा है? ये वो है कितना? Bardo. Give me a glass bar for smoothing the cavity.
Sir, what's your take on the complete or the near complete removal of the mucosa of the mastoid in canal wall down? And that is in relation with the incidence of weeping cavity lateral.
Mucosa, you're asking whom?
Yes,
Mukherjee,
sir.
But Nitin is asking what? Canal wall down.
The importance of leaving behind or the total clearance of the mucosa or the mucosal island, the small mucosal island in the crypts of the mastoid cavity.
Correct.
Because such cases is I was asking such cases in relation with the incidence of
Recurrence.
the whipping cavity.
Whipping
later on.
cavity, recurrence, etc. Yes, very correct. And we have to make the margin shallow also, so that we can cover up the whole thing, obliteration.
Was.
Yes.
authorization.
Socialization, that is the right word.
This is a big mastoid cavity. Sir, what's your take on the use of some musculoperiosteal flap for the obliteration of the cavity?
He has already taken inferiorly based flap already before surgery, before starting.
Oh, okay. That part I missed.
Okay, I am now going for reconstruction. I'll take a adenylate elegant.
Yes.
So I'll go. Yeah. How is the cavity, sir?
It is very clean. Very clean. I am liking it. Rather, I am loving it.
In the sinusoidal angle, there appears to be a little overhang.
Thank you, sir. Thank you.
Master of cochlear implant is doing masterectomy also. That's good.
Sir, what is the audio-visual part? I am doing audio-visual thing.
It's absolutely fantastic.
Absolutely fantastic. Ekdam correct. This is the right word.
Except for the initial glitch, technical glitch.
Yeah, sir. Actually, what happened?
Always happen in any sort of thing.
No. So what happened actually in gynae OT, na? Because
you have to change the OT straightway.
So because the gynae OT was little delayed, that's why I have to change from OT1 to OT2. Our broadband was in defined OT actually, sir. That OT. Because it is due to broadband, we are getting all this visualization. So I'm taking.
So can you tell us how you plan to reconstruct?
I'm taking cartilage from different places. Cartilage from tragus, cartilage from concha, cartilage from floor also, most probably. Let's take this floor cartilage. Because while I'll remove the floor cartilage most of the time, because I'll do metaplasty. This takes, let's take conchal. This the vein is there.
So you can take a nice piece of conchal cartilage.
Yeah. Sota elevator, micro elevator. I've seen a vein there. Can you appreciate a vein here? Yeah, it will definitely bleed. Consider bipolar. So I am using first time bipolar, the whole case. ये क्या है bipolar कहाँ गया? Am I right, Ahmed sir?
Yeah.
Because I have seen very small vessel here. You start already bleeding. Mop देखो ना यहाँ पे. कहाँ है? मैं फुट पे दो. कौन तो? हो गया. चलो. छोटा the knife दे. A Novarose is there. It is called PG from GMC.
Suri Prabhu sir will be really happy to see your use of bipolar, the minimal use of bipolar or cautery in the whole of the surgery.
Suri Prabhu, Anupam
Yes.
Hazarika fan.
Huh?
I have heard the name from Anupam Hazarika actually.
Yes. Yeah. He's a master in not using any type of cautery in your surgery.
Yes. So actually in the implant now, what happens if you do more? Sometimes it's required. It's not like it does not require. But what happens if you use a monopore for flap, it contracts in it's in implant. So that's make the habit of not using monopolar. So this is a piece of cartilage. So I'll make an incision here. Then I'll take this cartilage now. Consider. And this much is enough now. My micro elevator देना मेरे को. Itu di bawah desa. हो जाएगा सर. और ये मेरे को vascular force का तो वो force automatic force देना. छोटा जितना छोटा. I have seen your skin. दे फटाफट दे.
Huge forceps. छोटा सी जाड है ना. एक छोड़ देना, एक बार छोड़ देना. माइक्रो एलिवेटर देना थोड़ा. माइक्रो एलिवेटर दे. माइक्रो एलिवेटर कहाँ गया? Yes, sir. So no hole here, sir. Can you appreciate no hole here? No hole.
Full cartilage,
Okay.
no hole, sir.
No hole.
Good. Hole and hole.
No hole, sir.
No.
Ideally, one should see the cavity straightway for the canal itself.
No. I'm taking some concal cartilage now.
Concal cartilage. Oh yeah.
उसको डिटेक्ट करना संसिता. सीजर दे. सीजर नहीं तो नाइफ कुछ दो. আসলে হলু সিজাখন কই গল পয়েন্টেড সিজাখন. I have a pointed scissor also, no? It's a bigger figure now. Bigger figure. Knife dena. Bapare kata nahi kya? Knife. इसको पकड़ो। ये तो कौन धरेगा नहीं सकता। धरना पकड़ना। Sorry. Little bit of cartilage. Okay. Looks like a no. There's a small hole inside. Okay. Okay, and let's see here. No, if I was very মানে স্যার হৰু বস্তুটো এটো cartilage these children.
Your area of dissection has gone outside the field of vision.
Just a minute, sir. Just a minute. मैं यहाँ से उठाएगा। ये सेंटर है ना ये कैमरा सेंटर में है अभी।
Now it's okay.
Okay, just a minute. So this piece of cartilage, sir. Conchal cartilage, sir. Okay.
Can you recheck for us the hole in the concha?
Yeah. Knife गिर गया वो. Consider. No, sir. देना knife देना. वो दे knife नया knife दे. फटाफट. इसको रहने दो. सर अब सर वो कहाँ गया? तुम्हारा वो cartilage कहाँ गया? So how, Nitesh sir?
Yes, boss. Yes, boss.
How will you use this conchal cartilage for reconstruction?
How do you use? Boss, it depends on people's preference. I mean, like for what they are doing it, for what they are removing it.
So
we can use it for ossicular reconstruction. We can use it for cavity obliteration. We can use it for posterior canal wall reconstruction. We can use it for ethnic reconstruction. We can use it as pellicet for tympanoplasty. There are n numbers of uses of cartilage.
This part. Do you use with the perichondrium or without? You remove this part? Or you
No, sir. Please don't remove the perichondrium.
Yeah,
just remove the soft tissue over the cartilage or over the perichondrium, please, and please save the perichondrium.
Yeah.
Yes.
This part.
We can use a small scissor and then cut the excess tissue, but then it's always better to preserve the perichondrium.
Because there's no epithelium there, so
yes,
keep as much as possible.
Don't
remove that perichondrium.
When I'm not removing inside this muscle, I'm removing a little bit of. But it does not require.
Scissor is a better option.
A knife might strip the perichondrium, huh?
Vishnuji, you are going to do ossiculoplasty for this, na?
No, not with this. I'll just going for.
Huh?
I'll do with the tragal cutlass. I'll use for ossiculoplasty.
Canal reconstruction.
You'll do in second stage.
No, I'll do.
You'll do now itself.
And for what do you plan to use this conchal cartilage?
I'll mostly at reconstruction.
Post-tracheal wall.
Reconstruction of?
Attic.
Okay.
I'll take another cutlass for ossiculoplasty. आ गया नाइफ आ गया ना कहाँ है इसको रखो और कहाँ गया ये ठीक है निकलना again same process yeah fogging wait microscope to fogging हो गया कहाँ गया
Which type of ossiculoplasty, sir, are you preparing? Are you thinking?
no ossicles are there, so I'll take a vertical strip here from here, and I'll make a L-shape cutlass as one limb will for the
That we can do. We can also do with the conchal cartilage, no?
So no need of more cutlass.
That's what I'm saying. If you are not going to utilize a lot of cartilages, then the conchal cartilage should be enough. Or we can at least try to sculpt it out and see whether it is enough or not. If it's not enough, then we can always go through a triangle.
No,
What do you say?
No, tragal cartilage, I found more study actually, rather than conchal cartilage for ossiculoplasty.
Okay. Oh, it's personal choice actually. Some people say the most sturdy cartilage that you can get is in the floor of the canal.
I use sometimes, that's
The
also.
cartilage is the floor of the canal.
But I am searching the floor cartilage. Skin out. नहीं फोगिंग हो रहा है मेरा माइक्रोस्कोप हमारे को मार्क्स में ये लगा दो ना ले फटाफट संचिता अच्छा तो यार डायरेक्टली सर I am seeing also directly Allah cutlass kan ini lah so plaster लगा दो ना फटाफट adult it is easier to take this cartilage all these cartilages now here you see हो जाएगा हमको वर्टिकल स्ट्रिप ही चाहिए तो ये दिस मच इज एनफ this तो मैंने वर्टिकल इंस्टीट्यूशन तो दिस आजकल ये थोड़ा नाइफ लुक क्या हो गया एक बार काटने से नहीं काटता है ना रोजिना संचिता एक बार काटने से नहीं Can you appreciate how I'm taking the cartilage? And I will always keep one this most lateral most cartilage of the tragus so that there is no deformity of the tragal area. This mass cartilage is, I think, enough. I need a vertical strip. How can I sense it? Is enough? Okay. This for चलो यहाँ पे इसको नाइफ रखो इसको अभी मास्टर डिटेक्टर दो मास्टर डिटेक्टर कहाँ गया कटलेट ना यहाँ पे है यहाँ पे है यहाँ पे है यहाँ पे है मैं देखा हूँ ये है दे सेक्शन फॉर मेजरमेंट यहाँ पे है तो इसको कटलेट को ठीक से रखो फोकस वो बाहर से करो वहाँ एफजल आ गया है एफजल एखाने बॉल पे रखा था बॉल रखा था वो आ गया हाँ ये छोटा सेक्शन दो कोई कुछ है छोटा सेक्शन दो मेरे को एलिवेटर दो मैंने को माइक्रो ये दो now you can appreciate the oval window area can you appreciate Nitesh sir
Yes, sir.
can you appreciate oval window
Sir, we can see, but the magnification is low.
बेड को घुमाओ ना
Margins are not clear, huh?
बेड को रोटेट करो
Is that your chorda tympani?
that is a part of the chorda tympani
Oh.
Yeah, he was trying to preserve it for so long.
but when I take the endoscope
Yeah.
diabetes has gone endoscope ने मेरे को सब ले लिया ये
You can do suturing.
Suturing of what, sir?
End-to-end suturing of chorda. Bishop.
can you give me bar
Sir, but
more chorda is not here I'll do.
end-to-end quota suturing, sir.
Bishop might be able to do. Bishop might be able to do.
Huh, sir?
Bishop might be able to do that end-to-end
और थोड़ा
suturing.
घुमाओ ना
Yes, probably. Probably.
बाहर दो ना मेरे को बाहर दो थोड़ा
Now the window is coming in view.
जाकर छोटा डायमंड बार दो ना एकदम होड़ा लगा दो so I'm going to remove little bit of ridge of bone here sir Nitesh okay
Yes, sir. I prefer that.
Pani irrigation. Yeah. Not for cholesteatoma purpose, for visualization purpose. Now you can most fully appreciate the oval window, no? नहीं तो एंडोस्कोप लगेगा क्या? I have seen the mucosa over the oval window. Can you see the round window now? क्या आवाज आ रहा है? क्या आवाज आ रहा है? नहीं मत खोलो तुम हाइड तुम काम करो. But if I make a, if I how will you put the cartilage? There's a malleus is here, remnant malleus is here. So how will you put the cartilage? But यहाँ पे रखना पड़ेगा. रेफरेंस নহয় চাগে এইটো হয় এইটো হ'ব লাগে পিছন নপোৱা দে ঘূৰি আছা বস্তুটো এনেকে হয় your anatomy is like this way. Now it's okay. Yes, how now can take a scope. The scope देना light देना your anatomy is light दे scope दे scope देना 0 डिग्री केवल पानी दे
ये ऑफ करके ऑन कर
देखना हेरो सा नितेश्वर देना और मेरे को
Now your windows are very well seen, huh?
Can you appreciate the windows are all these windows?
With the Biswa orient ourselves, orient, please orient.
So this is oval window area. This is the horizontal portion of the facial nerve. This is the processus cochlear formis.
Hey, point it out with a pointer. Iman dangor suction to a point kurisa.
ये क्यों हो रहा है? Light थोड़ा हटा दो ना, थोड़ा पीछे वाला light हटा दो.
No, with a suction you cannot point out.
No.
Use a needle or something, huh?
Sir, this is the oval window.
Oval.
Is there some superstructure left?
No.
Nothing is there, no?
Nothing, sir. Normal hearing.
But mobile.
No, yes, sir.
Then so. Then
But
round
normally-
window.
This is your round window, sir. This is your round window. Round window niche, sir.
Yes. Then where is processus cochlear formis?
This is the niche where you do cochlear implant.
Yeah, processus cochlear formis has that tail hanging from it.
Tail.
The muscle, that one.
Sir, this is
Yes,
the extraction tube.
Extraction tube.
Can you appreciate the efficient with carotid bulbs?
Yes.
Can you see the carotid pulsation there? No.
You can see the eustachian tube or reciprocal thoughts.
Sir,
Processus cochlear formis.
Yes.
Jot lagai dise.
Oh, there, no?
There you can see the remnant of the
Processes
muscle.
cochlear bones কেতিয়াও destroy নহয়।
Hey, the muscle tendon is there.
So, sir, how will you put my ossicle, sir? Now the ossiculoplasty. How will you do ossiculoplasty? देना cartilage देना एक बार। Diatomy नहीं सही अभी।
ফুট প্লেটৰ গ্ৰাফটো সৰুকে গ্ৰাফ এটা দি পেলাই এডাল কাৰ্টিলেজ অকণ থিয় কৰাই দিয়া তাৰ ওপৰত গ্ৰাফ এটা দি থৈ দিয়া আৰু কি কৰিব মাইৰিংগো ষ্টেপেডোপেক্সি মাইৰিংগো প্লেটিনোপেক্সি আমি আগে বলছি তোমার থেকে
उसको नहीं हम ऐसे करेगा
माइरिंगो प्लेटिन
पकड़ना तुम स्कोप को पकड़ो
माइरिंगो प्लेटिनोपेक्सी very good
may not be very easy to keep it stable
इसमें देना नाइफ देखो ना यहाँ देखो साफ करो साफ करके लिखो गोस्ट पीस दे गोस्ट पीस दे
কাৰ্টিলেজ অকমান থিয় কৰাই দিয়া ফুটা করতে
তাকে সাইডে কইছ ৰব
সেইটোৱে কৰা পৰ্দা বেসটো বনাই দিয়া ওভালিন্দৰ ওপৰত এটা কভাৰ এটা দিয়া অকমান দি প্লাই কাৰ্টিলেজ পাতল কাৰ্টিলেজ দিলে হল তাৰপৰ কাৰ্টিলেজ থিয় কৰি তাৰপৰ এইটো বহল কৰি বেসটো আৰু এটা পথালকে এটা দিলে ভাল আছিল নহলে গ্ৰাফটো নহল গৈ পাৰে
লৰিব
So you're planning for the L strut?
Yeah.
Nidhi sir.
Sir.
Hello.
Myringo platinopexy will do, no?
Acha, yes. One thing, Bishop. I feel one just like Madhuri Mehta does. Just put one strip of cartilage to maintain the middle space. From the
we have discussed.
You can put one here. Strip of cartilage, then you put in the graph.
That is no. You have to put a longitudinal on the ovardius. Then also, again another. Then also the fasa you have to give. Otherwise, they are not correct.
Can you appreciate how big the cartilage is?
Sir?
Very big, now.
It's very big. It's very big.
One, it is. It will not transmit any sound.
Just I'm measuring. Okay. I'm getting an idea just. Okay. इसको लेके आओ. पकड़ो स्कोप को. ये देना, गॉस्पिस देना कुछ. इसको वर्टिकल बना देते हैं हाफ. होगा साइज से
हेरी আমাৰ হেৰি আছে নি
এটা এল ষ্ট্ৰেট ৰাখিব পাৰি যদি চোৱা
क्या बात है
শম্ভু আছে নি
কোনটো লাম
Number kita soalnya biskut tuh mana kia nih dari googly tuh bayar. 50-50 googly, exec. Ayo kita di pan juga.
Itu loh ya.
Itu jalan ya. Di biskut. Kita harus papore Ariel ba. Saat Excel. Mursumi 2 kilo, half kilo. 1 kilo tak pakai tuh mulu. Bol soda juga. Jadi tak saya sini dia mobile saya, Google saya beri mobile.
Action करना, इसको रखो, देना section दे.
Nanti ini कोई ले बेहा पाए terus.
देना.
Dua, तो मीठा से दिबो मो कहलिब
उल्टा हुआ है ना अभी भी बड़ा है, उसको काट सकते हैं हम, उसको नीचे लगते हैं।
Sir, have you
You don't know.
Sir, have you prepared where the other end of the cartilage will be?
Yeah.
Depression, anything, anywhere? Yeah.
Yeah. नहीं मैं actually deaf
Yes,
देख रहा
that end.
Yeah. नहीं
Are
actually
you planning to keep it? Are you planning to keep it in the hypotympanum or?
नहीं मैं actually पहले vertical height देखने वाला हूँ। Vertical height कौन सा जाएगा? If you put a hypotympanum, उल्टा भी कर सकते हैं हम, इसको इधर लेके आ सकते हैं। रुको।
No, sir. I would prefer that end. Yeah. That end to stay inside.
मेरे को घुमाने दो।
But again, still it's quite large.
Too much.
और कोई नहीं होता, और कोई problem ना है। Height to silence. क्या height is ठीक है ना यहाँ पे? नहीं थोड़ा और जाएगा नीचे।
हाँ है किधर का?
हाँ।
सारे टुकड़ा काटे बड़े पथाले के दी तापर ग्राफ को दी दिया।
Exactly.
क्यों करा काटे ले तो बड़ा बड़ा पथाले के दी बात ये स्टेबल हो।
Exactly. तो इसको थोड़ा और सूटी करना पड़ेगा।
हाँ, तो क्यों दिया पर? Yes.
That's why I'm measuring the height actually, sir.
Okay.
If you go too low na, can you appreciate?
Packing करा. फिर वो overload के दागड़ में नहीं ग्राफ तो माने इधर cartilage
this height is also big. I'll cut here, sir. Okay.
और कौन short करा?
Come on, just. That's why I'm measuring the height actually. Then I put the graph. It's okay, Nitesh sir.
Short and thin.
Sir, height, the measurement of the height and all, it will depend on how much the middle ear space you want to keep.
Yes.
If you want to keep too long, then we can keep it longer. If we want middle ear space to be a little bit lower, then we can keep it short. However, it also depends on the other end, where you want to put the other end.
Other end.
Yeah, not the foot plate end, but the another one, the another end. The lower end.
Problem is that na. Which one is the foot plate end? I forget now. Which one?
Yeah, that end. No. The rounded one is the foot plate end. The rounded tip towards your knife. The forceps side is your lower side.
Which one?
Forceps is enough. Forceps. No. Yes, sir. Ulta.
Sir, generally what I would prefer is we elevate the inferior part of the canal skin and then drill a space with a diamond burr just lateral to the annulus.
I know.
And then we put in that socket. Yeah, making a groove and then put it in that socket and then measure the length. That way everything is in fixed, and then we can measure the length as well as the height depending on how much we want to. And the height also, one of the measure factor will be how much high you want to reconstruct the attic, because you were saying to reconstruct the attic.
Then I have to make a. But look, Nitesh sir, since you have a very good anterior I have to make a limb in the anterior inferior quadrant.
What but you have to make a
anterior inferior quadrant, the groove.
Yes.
But the issue is that already there's a remnant. Only the remnant membrane is there. So I'm not interested to disrupt that membrane actually.
Why? Any specific reason?
Not as much that reason. I can elevate. I can again make a groove.
So,
but
are you going to do or just keep an underlay out there? Because anyway, your
okay. I can take this. I can do underlay. Just I'll elevate and I'll put there. Okay, take it. Chalo. There.
Yeah.
Detector lagao.
Sir,
No,
why I
but-
was saying is, if you remove the anterior part, no, towards the inferior part, then when you put the graft, it shouldn't fall. It will stay over the bone, and it will not fall.
Okay, okay.
It will not fall over the mouth of the eustachian tube.
ओके 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 दे 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 ये क्या बोल रहे हैं मालूम है देना मेरे को एलिवेटर दे नो 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 ये जो अभी लिया था एलिवेटर वो मैंने so I'll elevate from back okay Nitesh sir
Yes, sir.
I'll elevate from back
বিস্কুট রিয়েল পাপড় এমনি 320 টাকা আছে হ্যাঁ 320 টাকা তাতে আছে আর মৌসুমী দিছি 150 টাকা হ্যাঁ 30 টাকা আছে আর
যে 500 টাকা ছিল যখন 320 টাকা আনো 180 টাকা আছে না
এখন এই মৌসুমী গেল 2 কেজি
ও দিদি কিমান
150 টাকা
ও কি দেব আর কল
কলার 30 টাকা
Nitesh sir is I'm doing right
Martin,
thing
mute kara lo.
Yeah, we can elevate a little bit more to see, as well as in order to decrease the tautness of the to make the flap more flexible, we have to elevate a little bit anterior as well as posterior also.
side name देना और ये circle name
I think posterior part. Yeah, yeah. Now the anterior part.
तो circle name देना मेरे को
There's the annulus, no?
हाँ हाँ
Annulus, we can cut it off. I mean, like it's already separated. It will only cause hindrances. By the way, sir, one question is there in my mind. At this time, why do you choose to do endoscopy?
नहीं I am endoscope for visualization मैंने change नहीं किया time के लिए I think this is enough I can put this group over this group okay
Yeah. Yes.
okay okay
Yes, yes.
okay are you happy
Yes. The anterior part, I'm still.
दे cutlass दे हाँ कौन सा cutlass है
Sir, are you going to prepare any group there?
तू सही है अंडरले कर देंगे ना अभी
No, no, no. The group for the cartilage and the lower part of the cartilage.
छोटा बाड़ है एकदम छोटा एकदम कोक्लियर का बाड़ है ना मैं
There is something called Heermann's type 3 osteoplasty.
ये लोग सुनने वाला नहीं है मेरे को छोड़ दे जल्दी दे Can I take microscope now because already you have seen all the
I prefer
because इसको रखो
Microscope we can see nicely also. मुखर्जी क्या करता है
मेरे को सिकल नाइफ देना एक बार मेरे को सिकल नाइफ देना एक बार
What are you doing now, Mr.
नीतीश सर ने के लिए ग्रुप सही है सर
Which one?
सर ये सब
मैं कहाँ में ग्रुप बनाएगा
Inferior margin.
बुझा ना कोई ग्रुप बनाए I don't know where you will put the good.
And it is okay.
Just see if it will reach even, huh?
Yeah?
It has to reach that area.
Which one, Gurudev?
সেইখিনি ঢুকি পাব লাগিব group 2
Group 40 cartilage graft.
No, sir. Group for the lower end of the cartilage there we are going to use as for the osteoplasty.
Yes.
There are two ends. One end will stay in the over the foot plate.
Yes.
The another part, the lower end, will have to stay somewhere, whether it's in the hypotympanum or whether it's in the groove or whether it's in somewhere. It has to stay somewhere. So when we prepare a groove, then it stays in that area nicely in its own place.
The group is for the upper part. Huh?
No, sir. Group is for the lower end of the cartilage.
Lower end.
This is actually what
but this height is little low.
Length of the lower part is less now.
Sir, what I think is the foot plate end also is little bit wider. Actually, generally what I used to do is I used to make the groove and then only I prepare the cartilage. Before making the groove, I don't prepare the cartilage. Because that way we measure the cartilage in that area by putting in the groove, and then we measure the length, and then only I go for exact calibration and sizing of the cartilage.
Yeah, a little bit of shortage of this length. I can put different cartilage.
The inferior part, the inferior. But still, sir, chal jayega. Still, it's quite good. It's something like a triangle. The only thing what I feel is the superior part is little bit wider.
You can narrow down the upper end. You can narrow down the superior end, which will rest on the foot plate.
Different cartilage. No. This cartilage is not here. Okay, वही cartilage दे. साफ किया. कहाँ गया? साफ cartilage कहाँ है? No. Second life. Actually, some hair was there. Actually, that's why I removed that one. Second life. Sorry. वही दे ना. Second life कहाँ गया? Which one was the? This one was the man. This one? Are you sure? No. This one is ulta. Okay.
Almost finished. Almost finished.
क्या है इसमें वो?
You let me know when you start.
ये क्या है इसमें? कोकोनट लेना, कोकोनट फूड से देना. ये कहाँ से आ रहा है ये?
What happened, boss?
Hey, here है यार.
The fiber.
हाँ.
It comes quite often. I'm also really frustrated when I see fibers like that.
कहाँ से आ रहा है ये?
आपका लिनेन से
हेयर कैसे आएगा?
through your instruments.
मेरे को ग्राफ देना, ग्राफ दो। ग्राफ दो।
So the one, the end sitting on the oval window, is it too wide or is it narrow
ठीक है
enough?
सर, सर you have magnify image.
Oh,
I'm seeing. हाँ.
अच्छा अच्छा.
अगर मैं और छोटा करूंगा वो वर्टिकल हाइट मतलब इट विल बी
नहीं सर, छोटा वर्टिकल हाइट के लिए नहीं, जो width है ना, width
ये ठीक है.
Is it all right? Wide enough?
If that area is, it looks little wide, yeah.
Little light, but I am comfortable
If that
because
area is wide, then it stays.
देना फटाफट दे ग्राफ. But I'll be more happy if the cartilage is little vertical height. Yeah. This is the graph, final graph, sir. ये तुम रोज वेट ग्राफ यूज करते हैं या ड्राई ग्राफ यूज करते हैं सर in this kind of cases?
I always do a wet graph. Nowadays, I'm more afraid of doing a dry graph.
Why?
I don't know. I have been trained like that, and my common sense is why put something, dead? Why put something dead in the air? Even though it is supposed to be, some people say it gets absorbed, some people say it gets absorbed.
Sure. Sir.
We are putting the graft in place now.
Yeah.
Yes. Yes. Almost no problem. Bas. Yes. Shabash. Arrange koribo lagibo.
Arrange koribo lagibo.
You have to turn the furniture around.
Cartilage कहाँ है? Cartilage कहाँ है? Uncle cartilage कहाँ है?
Pull the skin ends out.
इफाले बेसी टाइले इफाले नाइकिया हो जाए.
Boss, do you prefer to put the cartilage first like this and then do the grafting, or after the grafting you put a cartilage?
Anything, because looks this becomes a rigor mortis graft, na? Someday cartilage there.
One of the reason I was asking is maximum manipulation is done during graft placement.
Yeah.
And if we put the cartilage already there, then it may give, of course, in good hands it doesn't happen, but in a little less experienced hand, it may give more pressure in the oval window area and cause subluxation of the.
You have a soft tissue. ना एल्गल दो मेरे को. एल्गल दो, सॉफ्ट टिश्यू दो. दे. Kindly mute. Some sounds are coming actually. I don't know.
Somebody is eating something or what? Huh?
Sir, is the edges of the graph rolled out, something like that, in the anterior
no,
part?
no. I am tucking inside.
The edges, no, the wet part, just posterior to that.
Yeah.
No, just
No.
posterior to that.
Yeah.
Sorry, not the posterior part, the anterior. I mean, the anterior where you put the gel form and just posterior to the gel form.
I am repositioned.
Superior to the gel
This is
form.
the anterior flap.
Yes. Yeah, the edges look rolled in. The remnant.
This is the remnant.
Yeah, it looks rolled in from here. Yes, sir.
No, Nitesh sir.
Sir.
This is your monitor. Where you are seeing me? In the laptop or here?
Mobile. Looks like a little rolled in.
Yeah. This area.
Is it?
नीतीश सर म्यूट करो ना, तुम को-होस्ट है।
हाँ सर।
म्यूट करो ना, आवाज आ रहा है। Now it's okay. Now it's okay.
Yeah, much better. I prefer to look it like that.
फ्लैप है, ये फ्लैप है। थोड़ा हेड को उधर घुमाओ ना, थोड़ा उस साइड। तुम मत करो, हाँ, जिसको नहीं आता है। हाँ। It's okay. Now can you see the apex of your membrane, remnant membrane? Nitesh sir. Now see.
Sir, थोड़ा centralize करो.
Now see, can you appreciate this is the anterior, what I can say? This is the anterior edge of the remnant. Okay.
Yes.
So this is the remnant rump. It's overlaying over the graft. Okay.
Yes. Now I'm happy. Yes.
Okay. now अभी अब जल डालो। तुम जो बोलेगा हम वही करते रहे। और कटर बनाना है क्या कहीं पे?
No, actually, was it rolled in? The margins was it rolled in?
थोड़ा हाँ। I am about to go up. I am about to do work on up actually. That's why I'm just tucking the inferior portion. You use ointment or something else? No,
sir. It's just Ciplox de-soaked this gel foam.
Okay. So it's okay, I think.
Yes.
Now whole this thing is covered. Now I'll go for. Actually, you can put some soft tissue here sometimes, but no, stitch kato isko. No. What about the myotoplasty?
We have to do.
Knife do.
Boss, if you can, zoom out a little bit for the myotoplasty, it will be much better. Just more zoom in.
Yeah. That's okay.
Yes, much better. Yes. Love it.
So, कौन है? तो इसको पकड़ना. I will remove part of cartilage. So this will go up. This will. नीचे से ठीक है ना? What is this? क्या हो रहा? क्या बोला? So this is epic partner. So I'll go this portion I'll
Bishop, finish only, finish.
কোনে কৈছে
মই
মই মানে ধৰিব পৰা নাই
ফুকন
ফুকন মাতটো কিয় বেলেগ আহিছে
মই মাস্ক পিন্ধি আছো আৰু ভাঙাঘৰত আছো গৈ আছো
নাই হোৱা জাষ্ট মিয়েট'প্লাষ্টি
দেখিছো মই কৰাটো
ইজ ওকে নিতেশ্বৰ
মিয়েট'প্লাষ্টি
ই পৰ্দা লগাই আছে
পৰ্দা নহয় গোটেই পৰিষ্কাৰ মাছ
sorry.
Generally, previously we used to say no, it has to be a finger wide. The finger should easily cross in. But nowadays, what I would also think is in the days of endoscopy, there's no need to be that much wide. Sir, what's your view on that?
এনেকে ধৰা and Vijayendra sir always remove this floor cartilage because he tell that there is springs, but I don't think he require this cartilage to be removed. हो जाएगा. It's adequate. Just I'll go. Decay little. Now I'll do little bit of. No, एक diatomy देना, monopolar देना. Monopolar दे. Nitya sir. Nitya sir.
Yes, sir. Yes, sir.
You have seen this. This is there's a little bit of pocket here in the mastoid. So what we do generally, we this muscle, this most lateralus portion, I release it. I take it towards the mastoid cavity.
Sure.
Sir.
This is the inferiorly braced muscle flap.
Yeah.
Yeah.
मेरे को वो देना एलिवेटर कुछ दे
वो असिस्टेंट तो था कोई
नहीं ये एलिवेटर नहीं माइक्रो एलिवेटर और ये
भाई অনেক ডাক্তার
দেখুন
এখনো 11 জন আছে
সেকশন Mukherjee sir, can you appreciate? Mukherjee sir.
Yes.
Can you appreciate the muscle rotation and?
Yes, I can appreciate.
Obliterating the cavity.
Even the cartilage you have put in things like that.
Brickle अभी. Brickle अभी. How the audiovisual things are? Cut this one.
Audiovisual is good.
Good now, sir. No hiccups now.
Hiccup was right in the beginning.
Yes, sir. Because of we're not getting the OT, main OT. So we have shifted to second OT.
Okay.
So stay susar for the gato. स्कोप नहीं सही अभी, लेके जा सकते हैं.
Will this also help in preventing retraction of that muscle graft?
Yeah, sir. They will work synergistically, synergetic way, like this metaplastic flap will be pulled by this rotation flap, and rotation flap is pulled up by metaplastic flap.
As long as the graft doesn't get pulled out.
Ha. Dana, kato. So for that, Sansita, you have to give a stay sisa up because it is falling down now. So pull this muscle, little bit of muscle, lateral portion of the muscle up. Okay. Not this portion, this portion. Okay. To up to stay.
Keep one end tucked into the canal.
Yes, sir. Yes, sir. So it is ahigal na ito. Then other portion will go inside.
Okay, that's good. One corner will go in.
Yes, sir. Then you cut it. Now what you do? ये काटा है ना, ये इसको ढीला किया है ना. Okay. So now we have done everything, but only one main suture is now. Another last suture is here. That suture is just a minute before this thing. I'll do this suture for superior suture for metaplasty. Okay, so I'll do it. This way. Kato. Is it okay, sir? Ahmed, sir?
Looks all right.
Now इसको पकड़ो. The graph को place करते हैं. Elevator of it.
You can check it from outside if it's adequate, nicely adequate. Put a finger and see.
मेरे को वो suction दो, कुछ suction या कुछ. That's why I need a bigger graph, sir.
Actually, our बड़ा होने से भी कोई बात नहीं था. और आरु अलग डांगर होले भाला सी.
हाँ.
है ना?
हाँ sir.
क्या लगी से मो?
सब साइड पे हो जाबो, किंतु but preferably should because it is coming here now, sir.
Yes.
So if now I can pull this muscle inside.
You can shift now.
You can shift now, or you can. So you can do one more suturing here. Just give me a suture. Is okay, sir?
Okay. Ekdam okay.
Looks all right.
No. But still I will give one suture here.
Don't put too many sutures in.
Yes, sir. Just yeah. Suture here.
It is nicely lining the cavity. Nicely.
Hope so, sir.
Oh, like good. Good.
Save the suture now. Okay. Good. Almost done. ले काटो. बस अभी इसको फेंको. तो ग्राफ टू लास्ट तक हिफाला कैनल अपना दे दिया. Let's go down. Place the graph like this. Okay. Now you can have to close, sir. Thank you so much. I think Sansita will close it.
Thank you.
And then thank you so much. I tried audio visual today actually.
Really good. What watching?
Sanchita, you have to close this shoe, sir.
Thank you, Biswa. It was mastectomy revisited for me.
Yeah.
Thank
Congrats,
you, sir.
congrats.
Thank you,
Congrats,
Khamsa.
congrats.
Congrats for
Right.
the audio visual.
Huh?
Congrats for the audio visual, na, sir.
No, it's
Congrats
okay.
for everything.
It is okay.
Congrats for the
Apply the
surgery, congrats for the audiovisual, congrats for everything.
इसको शेयर ऑफ कर देना अभी जस्ट मिनट सर यू जस्ट ऑफ दिस शेयर इसको स्क्रॉल करो शेयर स्टॉप शेयरिंग इसको अभी तुम गैलरी व्यू में लेके आओ
Okay.
Thanks, Biswa. We'll see you later on.
थैंक यू सर
Thank
थैंक यू
you.
सो मच
Thank you, Bishop.
थैंक यू सर बाय सर
Thank you, sir. Thank you so much. It was lovely.
थैंक
to
यू
watch.
ठीक है ना सर वनीता सर
Huh?
ठीक है ना
Oh, it was wonderful.
ओके
It was a very lovely.
ओके थैंक यू बाय ये हम लोग का
Bye bye. Good night.
बाय गुड नाइट इसको एंड कर दो मीटिंग को